Good morning, good afternoon, good evening, everyone. We are starting the second day of our international symposium in cardiovascular genetics. It's a pleasure for me to open the second day of lectures. And this morning here in Brazil, we will have 4 different speakers, and I am more than sure that you'll have a lot of knowledge, discussion, and it will be very profitable for everybody to be with us in the next 4 hours. And our first speaker is a friend of mine, Dr. Juan Pablo Ochoa. He's a director of cardiology of Health and Code, Coruña, Spain, research cardiologist specializing in genetics at Hospital Universitario Puerta de Hierro in Madrid, Spain. And he is also investigator of the Cardiovascular Research Group of the Medical Research Institute of A Coruña, Spain. Juan Pablo will be talking about dilated cardiomyopathy and non-compacted cardiomyopathy in the next 30 minutes, and then we'll have 20 minutes more or less for discussion. Professor Juan Pablo, please be my guest.
Okay.
Thank you very much.
Hi, everyone. Thanks, Ricardo. It's a pleasure for me to be here in this important symposium. I will share my screen. I will begin quickly with the presentation. So for the next, as you said, for the next 35 minutes, I will talk about the genetics of dilated cardiomyopathy and left ventricular non-compaction. So I will begin with the first one, that is the more known etiology, that is dilated cardiomyopathy. I think that the problem that we have is that we always divide dilated cardiomyopathy in ischemic versus non-ischemic cardiomyopathy. For example, we can have these 4 different echocardiographies. You can see that essentially it seems that they are very similar, but in fact, my screen has frozen.
No problem. Take your time, please.
Give me 1 second. Well, probably I will have to reinitiate the presentation.
It's okay. It's okay.
Sorry. Well, I was saying that essentially that in dilated cardiomyopathy, we are always talking about the ischemic between discussing if there is an ischemic versus a non-ischemic etiology, but you can see the screen right now, yes?
Yes.
Sorry. So, but in non-ischemic dilated cardiomyopathy, there are several causes that are associated with non-ischemic dilated cardiomyopathy. Genetics is one of that etiologies, but you have storage diseases, tachycardiomyopathy, infectious diseases, myocarditis. So essentially, we are putting a lot of different diseases in one small bag that is non-ischemic dilated cardiomyopathy. And I think that this is the reason why in some trials, for example, in the Nonisch trial, we didn't find differences in the utility of putting an ICD, for example, in non-ischemic dilated cardiomyopathy patients, but probably because we were not able to discriminate better who has benefit in these groups. If we talk about cardiomyopathies, dilated cardiomyopathy essentially probably is the second more frequent cardiomyopathy after hypertrophic cardiomyopathy. The incidence, the prevalence of the disease probably is between 1 in 250 and 1 in 2,500 patients, because it is not clear, probably more close to 100 in 500 patients of the general population. And with left ventricular non-compaction, we have some problems because there is not a clear definition. So the incident is rare, the prevalence is rare, but essentially we don't know what to call left ventricular noncompaction, and this is a problem. And probably a lot of patients with noncompaction are diagnosed in the other groups. So why using genetics in cardiomyopathies? I like this graphic because essentially these are the main 5 points. The first one is to make a correct diagnosis, identifying the cause of the disease. I mean, we need to know the etiology to treat in a better way our patients. The other is to perform the family screening, and this is probably the most important thing in genetics, and is that when we detect a mutation in the family that is disease causing, that explains the phenotype, we can go to other relatives and decide who we need to follow up or not. The third one is that we can add prognosis value and take therapeutic decisions. We will discuss on this because this is not so clear, but right now I think that we have a lot of evidence in this way. And the fifth is just to doing research. Essentially, the four first points, we use this to make a correct genetic counseling of our patients, to say what is going to happen with them in the future, what we need to do with those patients. I will show some illustrative cases, just 3 or 4 during the presentation, but just to have a better way to understand these diseases. This is a female of 30 years old with a familial DCM. She was diagnosed at the age of 14 of diabetes, and now she had 30, but 5 months ago she had a normal delivery of a child. But she began with paroxysmal atrial fibrillation, dyspnea, and when an echo was performed, he has a dilated cardiomyopathy, 68 millimeters of end diastolic left ventricular diameter, and 26% of ejection fraction. And on the laboratory test, there were some findings that he was diabetic. She was diabetic, so high glycosylated hemoglobin, and also she had hypertriglyceridemia with a very, very high levels of triglycerides in the serum plasma. But the father of this proband has been diagnosed at the age of 53, also of dilated cardiomyopathy. She has essentially the same history at age 38, diabetes mellitus, hypertension, dyslipemia. At age 40, permanent atrial fibrillation, so he began anticoagulation. At age 48, a pacemaker was implanted by a slow atrial fibrillation. The ejection fraction was 49, and at the age of 52, with the New York Heart Association class 2-3 with symptoms, an ejection fraction of 33, and dysynchrony in the echo, he was implanted with the pacemaker that had been implanted was upgraded to the TRC therapy and implantable defibrillator. So this father, in 2018, had a genetic testing that was completely negative with an NGS, a next generation sequencing panel of 126 cardiovascular genes, and the result was negative. So this is the family. There was also an uncle of the proband, a brother of the father, that has essentially the same phenotype of the father, but was not genetically tested because the father has been negative. But the three have dilated cardiomyopathy, atrial fibrillation with cardiac conduction disease, diabetes, and dyslipemia. So we perform a new next generation sequencing. First, we need to have some consideration about red flags that need to alert us that probably there is a genetic etiology when we evaluated these patients. The first is that if there is a family history of cardiomyopathy or sudden cardiac death, if you have cardiac conduction disorders, abnormal non-cardiological test or extracardiac manifestation, if you have a skeletal muscle involvement or just CPK elevation, ocular or auditory involvement, of if there is some liver or kidney abnormal functions. These are all of them some red flags that need to alert us that probably, with a high probability, there is a genetic condition. In this family, of course, we suspected the genetic condition, so we perform a new genetic test to the proband for a DCM panel of NGS. Here we perform a dilated cardiomyopathy panel of 81 genes, and we didn't detect any pathogenic variants in the study. There were no SNPs associated with the disease, but when we evaluated the copy number variation analysis, this is something that is relatively new and we can do in all the NGS study. We detected this duplication of the exons 5 to 10 of lamin. If you see the figures in black, you have all the controls, that these are all the people that goes in the row line of black, and in red, the coverage of every base in these exons of the patient. And if you can see in the bottom, the normalized coverage, there was an increase of 50% of the lectures of this patient, suggesting that this was a duplication of the exons 5 to 10 in lamin. We confirmed this finding with the Sanger sequencing because we were able to detect the breakpoints. The duplication was confirmed, and when we went to see what happens in this gene in lamin in the exons that were duplicated, we saw that there were a lot of mutations that are associated also with partial familial lipodystrophy that is associated with diabetes and high triglycerides. So this mutation was considered pathogenic. We did the co-segregation in the family, and the uncle and the father were carriers of the variant. And this is really important. And the first thing that I want to remark is that if you have a negative genetic study that was done in the past or even right now, it is very important to review the studies to see if copy number variations were evaluated, if all the important genes that are associated with disease were included in the panel. And for example, if you had a genetic study of 2012, 2014, or even 2020, but there are a new technology and the things are evolving so quickly right now that it is important to review all the studies, especially when you have these families with, it seems that they have a clear etiology. So sometimes it is useful to perform a new genetic study with the new technology that was what we did here, and we find the cause of the disease. And why it's important? Because once we find the cause of the disease, we can go and test the relatives that, for example, this brother of 35, the sister of 21, and probably in the future to test the daughter of this proband, because if they are carriers of the duplication in lamin, they need to have a follow-up. But if they are negative, we can dismiss and discard these patients from the follow-up. And if we don't perform the genetic study, these relatives should be followed all lifelong with echoes and ECG. And this is something that finally is cost effectiveness, because it allow us to follow just the patients that are positive. In most of the cases, these diseases are autosomal dominant, so 50% of the relatives will be dismissed when a negative genetic testing is performed and you don't detect the mutation that is the cause of the disease in the family. Another important thing is that right now that we know that in dilated cardiomyopathy there are a lot of works showing that there is a higher risk of the patients that have a positive genetic testing. This is a paper that we published in 2021 with the Puerta de Hierro Hospital, and this is the first paper that demonstrated in 1,000 probands that having a positive genetic study is associated with adverse outcomes in terms of cardiovascular events and end-stage heart failure, but also with a higher incidence of malignant ventricular arrhythmias. So having a positive genetic state is associated with more events, and also when we test the left ventricular reverse remodeling, that is a kind of way to see if there is a good response to the medical treatment, measured by the normalization of the ejection fraction or the increase of the ejection fraction at least 10% with respect to the baseline. We saw that the negative patient has a better, a higher incidence of left ventricular remodeling I mean, they respond better to the medical treatment than the positive genetic patients. But of course, saying if you are positive or negative also is an oversimplification, because this is the complexity of the etiology of dilated cardiomyopathy. You have mutations in the nuclear envelope, you have mutations in the sarcomere, you have desmosomal mutations, filament, intermediate filament mutations of proteins of the plasmatic membrane, or that regulates the calcium in the movement of calcium in the cytosol. So there are a lot of etiologies of dilated cardiomyopathies. So why all will respond on the same way? And this is another thing that was proved in this paper. It is not the same to having different mutations in different genes associated with different compartments. For example, lamin mutations are the worst in terms of malignant ventricular arrhythmias, followed probably by desmosomal mutations and cytoskeleton mutations, especially filament C. And if you see, titin mutations are essentially the same, that the evolution of the group with the negative genetic testing. So it's not only something related to being positive or negative, but also of which gene has the mutation. And probably we will see later that there are, even in one gene, different mutations associated with different prognosis. And also with reverse modeling, essentially is the same. If you go to genotype negative patients, 46% with the left ventricular reverse modeling, but in titin more than 50%. So titin essentially is a gene that responds good to the medical treatment. But if you go to the desmosomal or the nuclear envelope, lamin, or the sarcomeric mutation, for example, MYH7 in beta myosin, the response is not so good. Less than 30% of the patients respond to the medical treatment. And this is something really important to manage the patients. This is another patient, also with a lamin mutation, but I will show this to demonstrate that going deeper into the genotype, individualizing the risk by every mutation also adds information. This is a woman of 9 years old, well, right now is older, but she was diagnosed at 9 years old of muscular dystrophy. She had a history of dilated cardiomyopathy in the family. At age 17, in a screening, in echo screening, because of her muscular dystrophy, she had left ventricular dilatation and dysfunction with an ejection fraction of 40%. At the age of 21, she developed sustained ventricular tachycardia. Now the ejection fraction was 31%. You can see in the images the apical fibrosis in the MRI, in the echo. She had akinesia of all of these segments. So an ICD was implanted with several appropriate therapies. And in fact, she went to substrate ablation, but the EP team, because of this high burden of ventricular tachycardias. This is something new, but I want to use this. This is the Madrid Score that we developed this year, also with the same core that I showed before in the Puerta de Hierro. This is in the Journal of the American College of Cardiology. And you can see that there is this score that can predict which percentage of the patients will have a positive genetic study. And if we introduce this lady here, you can see that she had skeletal myopathy, a family history of dilated cardiomyopathy, absence of hypertension, and absence of left ventricular bundle branch block. So if you put, this is very simple, but if you put, he has 4 risk factors, and with 4 risk factors, she had a 78% of probabilities of having a positive genetic testing. And in fact, she had a positive genetic testing. This is the mutation that we identified in this lady, arginine 541 serine in lamin. And we know that lamin is associated with a worse prognosis. I showed that before in the 1,000 patient course of the Madrid Score. But this is where the risk factors that are used in lamin mutations to stratify the risk. And if you have less than 45% of ejection fraction, if you are male, or you have non-sustained ventricular tachycardia or a radical mutation, you have a higher risk, and it was postulated that with 2 of these 4, an ICD should be implanted. We replicate this in the Spanish court in this red lamina registry that was led by Coruña, but our group. And here, the only 2 factors that were associated with a higher risk of an adverse evolution in terms of arrhythmic risk were non-sustained ventricular tachycardia and the ejection fraction less than 45%. And if you see here, the patient that they don't have these 2 risk factors are they goes well, but when you develop dysfunction or when you have non-sustained ventricular tachycardia, the prognosis is really different. And there is something that is changing, because right now in the guidelines, and this was hard to think a couple of years ago, but right now in the guideline, this is the new guideline about the management of patients with ventricular arrhythmias. And if you go to the guideline, the pathogenic mutations in lamin are introduced as an independent risk factor. And if you have a pathogenic mutation in lamin with less than 50% of ejection fraction or non-sustained VT, or you have cardiac conduction disease and a pacemaker will be implanted, you should consider putting in these patients an ICD. And a couple of years ago, we were just stratifying these patients according to the ejection fraction. Right now, we have something different, and genetic is introduced in the guidelines to stratify the risk. But specifically in this particular residue, arginine 541, that was the mutated in this lady, if we compare this particular mutation, this position, with other mutations in lamin, other pathogenic mutations in lamin, this is a survival curve of free cardiovascular events. You can see that this 377 in green has this prognosis. The truncating variants in blue are worse than the 377, but if you have mutations in the position arginine 119, that is a hot spot, they have also worse prognosis than the mutation, the truncating variants. But look at this particular residue that we detect in this lady. The median of survival is 35 years old. So half of the patients will have a adverse cardiovascular event at 35. So really, this is a worse prognosis than the worst, that this is the lamin mutation. And this is just to have an example. Peter Van Tintelen will give the talk of hypertrophic cardiomyopathy. And this is a mutation in phospholamban. Arginine 4 deletion is a deletion of a single amino acid. And they have in the Netherlands a lot of patients with this mutation. And it is so prevalent that they develop an independent risk score for this mutation to stratify the arrhythmic risk. So we are going deeper into the genotype, and right now we are developing a score to stratify the risk in specific mutations. For example, in this case, it is very important because these patients have low voltages, negative T waves, and depending on these findings, you can stratify the risk, the arrhythmic risk, better than with the other scores. So genetics is really important, and in terms of risk and stratification and guiding the therapy with an ICD, probably this will be the future. This is just a reflection because this is an editorial of Domenico Corrado. I like this figure because he's talking about the new predictors for left side variants. I mean, all the variants that are associated with arrhythmogenic left ventricular cardiomyopathy. It means that this is a arrhythmogenic cardiomyopathy, but if you see the variants, the small plaque filamin C, lamin, TMM43, phospholamban, RBM20, and when we go to the 1,000 patients of our dilated cardiomyopathy cohort, the second, the third, the fifth, and the sixth gene in terms of frequency are the small plaque, lamin, filamin C, and RBM20. These patients are not diagnosed with arrhythmogenic cardiomyopathy. They are diagnosed with a dilated cardiomyopathy, and it is really important to consider that these genes are associated with the higher risk of arrhythmias when they are detected in dilated cardiomyopathy. This is a paper of Martin Ortiz that we made in Health in Code in 2016. he will give another of the later talks. And this paper was really important because it demonstrated that truncative variants for the first time are associated with this phenotype of dilated arrhythmogenic cardiomyopathy. And why was this possible? Because we collected all the families with mutation, because we have introduced this gene as a candidate in 2014. And when we saw the signal, we went to the families to look all the relatives and prove that these variants are associated with disease. This is the main figure of the shack. And of course, these mutations are associated with a higher risk of ventricular arrhythmia. They have mid-ventricular fibrosis, so a characteristic phenotype. But this is information that we need to use. This is unpublished, but we are working in this new paper of the Madrid cohort. And in the Madrid cohort, if we put and we divide the groups in major adverse events in terms of arrhythmic and heart failure in these patients, you can see that titin mutations are essentially the same. Titin truncating variants are essentially the same that negative patients. In green, you have the positive patients that had a worse prognosis, but in red, you have all the patients with high risk mutation, and definitely the prognosis is different. And this is something that also the new guidelines are considering. They are saying that we need to consider to put an ICD if we have more than 2 risk factors associated with the variant when you have a ejection fraction between 36 and 50%. And these risk factors are unexplained syncope, pathogenic variants in phospholamphin, filament C, or RBN20, the presence of LGE, and the inducible sustained monomorphic ventricular tachycardia in an electrophysiological study. But they are including these high-risk variants as a new way of stratifying the risk. Also, the LGE is included, and this is another sub-study of our paper of the 1,000 patients. And here you can see that if you have a negative genetic study, I think that this is the most important message. If you have a negative genetic study and you don't have LGE in the MRI, your risk of having arrhythmic adverse events is very, very, very low. So the predictive negative of combining the genetics with LGE is very important in stratifying the risk in dilated cardiomyopathy. This is just a kind of game with also the 1,000 patients. But if you go and use just the less than 35% criteria to implant an ICD, you will implant 55% of ICD, and 3.2 patients will have an appropriate ICD shock, so they will be protected. But in the other part of the curve, you can see that 3.3% of patients with more than 35% won't receive an ICD, and they will have an adverse arrhythmic event. But if we combine the strategy of using LGE and the genotype, probably we will put the same amount of ICDs, 55%, but we will have 6% of patients with appropriate ICD shocks, and just 0.7% of the patients will be unprotected and will have an event. If you want to use the high-risk genotype combined with an LGD, the LGE, the gadolemia, the fibrosis, you will implant only 30% of ICDs, and you will have 1.7 patients that will have an event and are unprotected. But this is definitely better than using the less than 35% value that you use usually. So moving to left ventricular non-compaction, I like this title because it's clinical and genotype complexities of left ventricular non-compaction, preventing overdiagnosis in a disease we do not understand. And I think that in a way is true, but I like this graph because essentially it says that if the only thing that you have is non-compaction as the definitions of the criteria that we use, for example, in this case, Jenny's criteria, but the only thing that you have is left ventricular non-compaction without systolic dysfunction, without family history, without a child, your ECG is normal, you don't have anything in the medical history of heart failure, arrhythmias, thrombosis, and the MRI has no fibrosis, no left ventricular dysfunction, and nothing altered, and the only trait that you have is the left ventricular non-compaction, your risk is low, and probably this is some physiological variable condition. But if you have any of these, especially family history or alteration, especially left ventricular dysfunction, probably it will be indicating to have a genetic testing, because this is really a left ventricular non-compaction, and it can be associated with genetic etiology. And what we know about left ventricular non-compaction, as in DCM, is that having a positive genetic study is also associated with a worse prognosis. This is a paper published in 2018, but essentially genotype negative, genotype positive, very few patients, just less than 100. So the numbers are are not so high as in dilated cardiomyopathy, but essentially it says that having a genetic test is associated with a worse prognosis. This is also was published in 2018 with more patients, and essentially it's the same, but the message is that in childhood, when you have a children with a genetic positive test, the outcome is worse than if you have a negative genetic test. It's not so useful in the adult, but of course, also having a positive genetic test is associated with the worse prognosis, and again, the left ventricular ejection fraction is associated with worse outcomes in genotype positive children. But, children, no, patients. And when we go to the etiology, essentially, we have an overlapping between left ventricular non-compaction, hypertrophic, and dilated cardiomyopathy. If you go to the isolated left ventricular non-compaction, the main gene is MYA7 beta-myosin, followed by titin and myosin binding. But if you have this etiology with dilated cardiomyopathy, of course, titin is increased because it's associated with dilated cardiomyopathy. Also, MYA7 is the first gene and the other ones. And when you have non-compaction with ACM, again, the myosin binding has a more strong association, especially because it's a clear gene associated with hypertrophic cardiomyopathy. And well, this is the percentage of the genes. Of course, titin, being the most prevalent, is a more frequent gene. This is something that the last year in a paper published by Mazarotto was demonstrate essentially the same. If you have left ventricular non-compaction with dilatation, titin is the first. With ACM, myosin binding. With DCM or ACM, and here the sarcomeric proteins as MYA7, troponin T, cardiac actin, tropomyosin. If you have left ventricular non-compaction with arrhythmia, ACM4 or ryanodine, and just left ventricular non-compaction with none of the others, and we have the genes MYA7, PRD, IM16, and actinin. But this is our experience in Health in Code with more than 900 probants that had a panel for left ventricular non-compaction, and essentially we have 28% of positive genetic studies, negatives 46%, and 25% were BUS. But essentially the numbers are the same. The more frequent titin with MYA7, myosin binding, actin, or essentially the same findings that the other people had in previous study. If we go to the more frequent, I named that before. This is a paper that we published also this year with the Puerta de Hierro group, showing the natural history of MYA7 mutations associated with dilated cardiomyopathy. Two important messages: there are not a high burden of myoventricular arrhythmias, but essentially the conclusion of the paper is that 16% of the patients are diagnosed with less than 18 years old, and the presence of non-compaction in this dilated cardiomyopathy is near 40%. So essentially the same findings that other people find before, but with a higher number of patients. Just a couple of cases to finish. Cardiac actin, PRD16, TBX20, all transcripting factors that can be associated with disease, NKX25. And here in non-compaction cardiomyopathy, it's really important to see if there are extracardiac features, because this is a clue to suspect a determined etiology. This is a 42-year-old male from Germany, diagnosed with non-compaction cardiomyopathy, not clear etiology. This truncated variant in KX25. When we review all the variants, all the truncated variants, this was a couple of years ago in this gene, we saw that the main phenotype associated with this mutation, of course, left ventricular non-compaction was one of them, but the main phenotype associated with this mutation was cardiac conduction disease and hair septal defects. And this is really important when you interpret genetic testing, is to see the phenotype. And it is really important for us that the clinician send us the clinical part of the case. So here, the only thing that we have is left ventricular non-compaction. So essentially, I wrote a letter to the physician that was following this patient, telling this, that I was surprised because this is a non-compaction, but essentially, if he had some information about cardiac conduction disease or atrial septal defects in the patient. And this is the response of the patient. Thank you for your email. The patient suffered from atrial septal defect, my left persistent superior cava vein, underwent surgery in the childhood. Additionally, she suffered from total heart block. A pin maker was implanted in her youth. So definitely, this is a non-compaction, but with this information, the variant is clearly pathogenic and it fits perfectly with the phenotype that we suspect. I talked with the filament C. These are different from the truncated mutations, but there are some missense mutations in filament C. In fact, there is a new paper published this year in the Spanish Cardiovascular magazine talking about this. But we have some patients with left ventricular non-compaction, big atrium, some degrees of hypertrophy, and we are detecting filament C variants that are associated with this particular phenotype. Something important, and in this case, there was a de novo presentation, but we have other cases as this one with left ventricular non-compaction, hypertrophy, some restrictive filling pattern, and these are mutations in filament C. That is a new gene, as you can see here, the flow in the trabecules of the left ventricle associated with left ventricular non-compaction. The last one, this is a case that we reviewed last week, so I introduced the case here, but essentially it is a Spanish cardiologist that sent the patient because it was, I think that it was a woman that had left ventricular non-compaction with some dilatation of the ventricle, essentially in the upper limits, 53 millimeters of end diastolic diameter, but she has a history in the mother and in the father of sudden cardiac death in the father and bradycardia in the mother. So essentially, there was some family history. So he asked for a genetic panel for this, and we detected this, that is the same that in the copy number variation as I showed before. Here in green are the controls. So you can see that the patient is in red, essentially is the same as the control, except in this part that is the exon 3 that has a deletion of the exon 3. If you go to the image in the bottom, you can see that there is a 50% of decrease in the lectures in this exon. So this is a deletion of the exon 3. And this is a pathogenic variant. We have 6 patients with the same phenotype that essentially is left ventricular non-compaction. Some of them have bradycardia, and the phenotype in ryanodine 2 mutations is CPVT, catecholamorphic polymorphic ventricular tachycardia, that this is an overlapping phenotype, and this is the only mutation in ryanodine that's associated with left ventricular non-compaction. So the importance to have a good phenotype in the patients and to look forward into the genetics, because this is really important for the management of the patients, because the risk here is not the dysfunction, is the development of ventricular arrhythmias, and all of the patients with this particular deletion needs to go for a stress test to detect the ventricular arrhythmias and a Holter to see if there are ventricular arrhythmias that are the risk of the CPVT. So finally, to conclude, this is my final remarks. Today, genetic testing is a fundamental tool for the management of DCM and left ventricular non-compaction. You have an etiological diagnosis. You put a clear diagnosis to the disease. It allows the familiar screening of all the relatives. And of course, knowing the etiology has some prognostic information, as I showed, and especially now with an ICD implantation, therapeutic implications. But in the future, probably a lot of these mutations, there are a lot of trials doing this, will have a specific treatment, especially with genetic therapy. The combination of genetics associated with tissue characterization, especially with LGE, with fibrosis, will be a fundamental tool in risk stratification of ventricular arrhythmias. And of course, genetic testing should be considered in all patients with non-ischemic DCM and left ventricular non-compaction. And remember, in low ventricular non-compaction, that if you have only non-compaction without family history, normal ejection fraction, you can consider this is a trait and not really a left ventricular non-compaction. And that's all. Thank you for your attention. I was 5 minutes exit for the 30 minutes, but open to discuss on this. Thank you.
Professor Ochoa, thank you very, very much for your fantastic talk. When you are in front of this kind of talk and learn, even studying the subject every day, you can say that it was a fantastic talk. And I was very impressed about the ryanodine overlapping between polymorphic catecholaminergic arrhythmia, ryanodine, with non-compaction cardiomyopathy. Really, you are giving us some new information that is awesome. But I would like to ask you something very simple. When I was with you at Coruña in 2015, something that I really learned was the following. When you have idiopathic dilated cardiomyopathy, first for me, it was idiopathic cardiomyopathy, point. Now, when I have idiopathic cardiomyopathy, maybe I can be in front of a genetic disease, a familial disease. First, what do you think about this? Because cardiologists, they are not aware all over the world about the fact that idiopathic cardiomyopathy can be genetic cardiomyopathy. And second, when I was in Coruña, you say, and the literature was saying that it was 40% of the idiopathic cardiomyopathies were, in fact, genetic cardiomyopathy. What you can talk about this for us?
Well, the first question, I totally agree with you. I remember that when I came to Madrid to learn something about genetics and inherited cardiomyopathies, I was working in previously in Buenos Aires in the Favaloro Foundation, that is the more important center in transplant, in cardiac with the program of cardiac transplant. So we had a lot of patients with, and we didn't ask to the patients about the family history. None of them had a family tree. And for me, this is one of the main messages, and I agree with you, Ricardo. One of the main things that we need to learn is that if you have a patient with non-ischemic dilated cardiomyopathy, probably it could be genetics, and you need to go for the family. And it is not enough to say, okay, do you have family history? Because the patients with family history, they understand a lot of things. Mm-hmm. You need to ask. Do you have some relative that has a cardiac transplant, that is taking medication for the heart, that has shortness of breath? It is really important, because I have a slide that I didn't introduce in the talk. But when we began to screen the relatives with echo, the diagnostic yield of genetic dilated cardiomyopathy increased from 10 to 40%, because there are a lot of relatives. So it is not just, okay, ask, but you need to go for the family and say, okay, I will want to do an echo of your sister, of your brother, to see if the ejection fraction is normal. So I agree with you. This is a main message. The second, we used to say that 40%. In the 1,000 patients, the diagnostic yield was 37%. So essentially, yes, I think that it is probably between 25 to 40. There is no no series with less than 25, but also not more than 40. I have my theories because probably 40, it means that there are not more patients with the genetic etiology over that 40, but with what we are doing right now, how we are testing the patients right now, this is the yield. For me, the important message here is that if you have a negative genetic testing, but you have one of the red flags that I showed before, and especially if there is family history, the negative genetic test, it doesn't mean that you don't have a genetic etiology. The only thing that you need to know is that you didn't find the etiology yet.
Okay. So maybe it's more than 37.
Probably, I think that it will be the same that in ACM. We have the same gene in ACM, no more than 40.
Another question, first of all, Dr. Thais Burden, congratulate you on the presentation, very enlightening. Her question is, if a genetic study is indicated in every left ventricle non-compaction case, every.
I will say that if you don't have a family history, I think that is clear in the slide of, if the only thing that you have is non-compaction as a trait, I mean, you have no, if you have ventricular dysfunction, I think that we need to consider that patient as a dilated cardiomyopathy and need to go for genetic testing. If you have in the MRI LGE, you need to go to the genetic testing. If you have a family history or other conditions associated with non-compaction as skeletal muscular disease or red flags, you need to go to a genetic testing. But if you don't have any of these conditions, you don't have dilatation, your ejection fraction is normal, you don't have family history, you can consider not to go for the genetic testing.
The fact is that in clinical, at the clinical ground, and at my clinic, I am used to see some patients, athletes, for example, and you know
Yes.
that I deal with high-level performance athletes. They have some criteria, myocardial resonance criteria for left ventricle non-compaction, and then I am in the gray zone. What should they do to disqualify for 3-6 months? Is not a good thing to do with these guys, and sometimes you can't do because they will not stop. What do you suggest?
If you don't have a left ventricular dysfunction,
no, you don't have anything else. For example, a professional paddle player.
Okay,
last week.
I will go for the genetic, in this particular cases, I will go for the genetic testing, because if you have a negative genetic testing, it's very reassuring in this case. I mean, you can say, okay, you need to follow up the patients, of course, because you don't know, but I think that the risk is really low, essentially because he had any of the red flags or other conditions associated with risk, especially ventricular dysfunction, and the genetic test is reassuring. So I won't discontinue the patient of doing sports just for this. And in these cases, the genetic study is really useful, especially when it is interpreted by experienced people in the field, because there are VUS, so you need to be sure that there is nothing in the genetic test. This is really important.
Yeah, the negative predictive value seems to be very important in this circumstance. And it was exactly what I have done. I did a performance genetic test, and it was negative.
It was negative.
He is playing.
I would expect the negative genetic testing in these cases. And it happens the same with the pregnancy and other conditions that are associated with volume overload or pressure overload, that they develop some trabecules or some kind of non-compaction, but it is secondary to the overload of the left ventricle. I mean, we don't need to do genetic testing for everyone in these cases, but especially if you are a competitive sports, and this is really important to see and to stratify the risk, it will help.
A question here from Dr. Mary Stewart from Melbourne, Australia. It's night over there. The question is, Dr. Ochoa, congratulations for your presentation. what else after the Madrid score?
What else? I think that the Madrid score is useful just to see. We have this discussion, especially in some countries as Argentina, Brazil, in which you need to select whose patient to test. But I think the main message of the Madrid score is essentially, if you have red flags, probably you will get a positive genetic testing. That is the only message. I think that is not, probably it will be not a tool to make the decisions. What we are working right now is after the Madrid score, in this big cohort of dilated cardiomyopathy patients, is to combine the LGE with the genetics to have a better stratifying and defining a new tool to predict, a better tool to predict the risk in these patients, of arrhythmia risk and the evolution of these patients.
Mm-hmm. I have another question for you. I don't know if Dr. Martin Ortiz would like to make a question or not, but please, if the audience wants to make questions, we have 6 minutes. And
if I can, congratulations on your talk, Juan Pablo. I learned a lot. My question is related with the previous one from Australia regarding the Madrid score, that age at diagnosis is not one of the criteria. And this is a recurrent question that people ask me in the talk. And if you need that there is a cutoff for age at diagnosis for a patient with dilated cardiomyopathy to go for genetic study. And in case if you live in a country that genetic study is a difficult task, if there is a cutoff for a patient diagnosis with dilated cutoff in the age of diagnosis of dilated cardiomyopathy for a patient to go to a familial screening, to clinical familial screening of the kids or brothers, etc.
I think that the age was not a factor because we have a very the population was not so homogeneous. This is a derivation center, so we have mainly patients. There were not so many pediatric patients. So I think that it probably, I would say that if you have, and the other thing that, well, it's different from with hypertrophic cardiomyopathy, in which I think that the disease is more spread. But for example, I showed the case of Lamin. But if you saw Lamin, usually the disease, the development of DCM begins at age 30, 35, the same with BAC3. So I think that in DCM, differently, except for some mutations in sarcomeric proteins that are developed in the childhood, usually it's a disease that in the main cases, even in truncating variants, the disease began after 30, and you don't have so many patients diagnosed young. But probably it could be something related to the numbers. Regarding to the case, the question of if there is a cutoff value.
Excuse me, but my big concern is the upper limit, because sometimes people say, well, my patient is 65, 70 years old, genetic study.
Well, but I think that no, here I think that when I give these talks about genetics and the question is who to test, for me the question is different. It's who not to test in DCM and ACM. So I mean, who not to test? Maybe that if you have 70, you have no descendancy, so your risk is not so high. You don't have a family history. You don't have red flags, and testing this patient is not adding value to you in terms of the family or the risk stratification. You can consider not to go for the test. But if you have a family, you have the ascendancy, I will go for the test, and I think that is not so important, the age. Of course, I think that this is something that you need to evaluate.
We lost him.
Yes, he's like a statue. as a statue. No problem. But I agree completely with Juan Pablo that in some circumstances there is no need to test. But and it's interesting his sentence, who I will not test, because when we are talking about genetic testing, I think there are something very important, Martin, that maybe you agree, that is what I will do with the test, for what I am doing the test. And in this example, he was making for us a 70-year-old without descendants. For what?
Yeah.
Why do
No,
you
I
test?
agree. I agree.
But I think that most circumstances, when you have pre-test, a high pre-test probability, or you are in doubt and the response can help you to decide what you will do or to perform a cascade evaluation, genetic test is very important. And Thomas Malthus' law, not Malthus, Reverend Thomas Bay law is very important here. Pre-test probability and what I will do with the test after the test is performed. So
yeah, I agree.
and you as an expert, you know more than me that this is very important, especially in low-income countries as Argentina and Brazil. We don't have, there are some patients that we know that they must do the genetic test technically, but there is no money to do this. So we can't.
Yes, it's a very big limitation for us.
It's for sure. Well, we lost Juan Pablo, and he need to travel from Murcia to Coruña and he has a flight in 1 hour. And after his fantastic presentation, I will give 1 minute of rest to take a glass of water. And we have a change. Professor Arsonval Moinier Jr. will give the next talk, and Professor Peter Van Tittelen will give the last talk this morning, okay? So 1 minute rest, and then we'll have Professor Arsonval Moinier Jr. Thank you very much. See you in a minute. Hello, we are going to the second lecture of this morning in Brazil. In Brasilia, it's 9:35. Dr. Juan Pablo Ochoa left us after his brilliant presentation, and now we'll have my friend and colleague, Professor Arsonval Lamonier Jr. from Belo Horizonte, Brazil. He's a medical geneticist and also a cardiologist, so a double he has his background in genetics and in cardiology. That is fantastic. He is from Belo Horizonte, Brazil, as I mentioned before. He's an investigator of the Cardiovascular Research Group of the Medical Research Institute of A Coruña, Spain. And Professor Arsonval will talk about aortopathy in the next 30 minutes. Professor, please be my guest.
Thank you, Ricardo. Congratulations for this event. To me, it's a big pleasure to see how cardiogenetics is growing in Brazil. And it's an important meeting to make some connections with people from all world. And let's start. I will share my screen. Well, our presentation is about inherited aortic disease, talking about clinical and molecular aspects. And like Ricardo Stein have said, I am a medical geneticist, not a cardiac surgeon. So I will try to do my point of view from genetics going to the cardiology. Well, in this topic, we have some uses that we have to consider it in this context. The first point in aortic disease is the consideration about syndromic and non-syndromic presentations for risk stratification and also the implications of it in the familial screening. The assessment of imaging strategies for diagnosis and follow-up of these patients, appropriated pharmacotherapy strategies and indications for surgery, the timing of surgery, also the counseling for pregnancy, and also the sports recommendation in these patients. This is can be considered the hot uses in the context of aortopathies. Just an overview, we need to consider that these diseases are clinically and genetically heterogeneous conditions caused by genetic defects in the connective tissues, proteins such as collagen, fibrillin, and elastin. A lot of these inherited diseases have syndromic presentations with involvement of cardiovascular system, muscular skeletal findings, dermatological, ocular, and even other systems are related with these pathologies. On the other hand, we have non-syndromic presentations that could be associated with or without heart defects, including the increasing interest in bicuspid aortic valve recently. These disorders are also associated with sudden cardiac death risk related to dissection of rupture, of course, but including other arteries could be associated with the mortality and comorbidity in these patients. And to the final consideration, we need to consider that these disorders have a significant phenotype overlapping and variable specificity that is also a big challenge for diagnosis and management of these patients. This is a picture just to illustrate the several genes and pathways related with aortic disease. Today, the available commercial panels, genetic panels for aortic disease have more than 50 genes. Here we have only the prior genes, the genes more related, associated with elastin, fibrillin, collagen remodeling, and this is a complex pathophysiological process that we are understanding each day with the advances of genetics and genomics, especially. Genomics has also opened other doors in this field. This is just to illustrate how the genomic science has put new targets for the understanding of aortic disease, like the nicotinamide phosphorybenzyltransferase enzyme that is implicating in the aging of the vascular tissue, and how the target therapy here is the statins, just to avoid the inflammation process. I think that in the next years we will have some new interesting points in this topic. Well, thinking in inherited aortic disease, we need to start always with Marfan syndrome. First description of Marfan syndrome has more than 50 years, and this is the classic phenotype. This syndromes, Marfan, and its differential diagnosis are always patients with high stature, Marfanoid habitus, with skeletal, cardiovascular, and ocular abnormalities. You can see in the picture the arachnodactylia and the patient with classical phenotype. Some signs should be on mind of the cardiologist in the clinical practice to raise the suspicion of this diagnosis of other syndromic presentation for aortic disease, like pectus abnormalities, pectus carinatum, pectus excavatum. Also the thumb and wrist signs, very related with arachnodactylia. The presence of scoliosis, or even more deep sign like dural ectasis, and some facial appearance is typical from Marfan patients with hypoplasia of malar bone, and other signs that we need to consider, like esophthalmia in these patients. Other major criteria for Marfan syndrome is ectopia lens. It has been reported in around 60% of the patients, often bilateral, symmetrical, mostly to upward. And lens dislocation may occur inclusive in the absence of trauma event. Usually the ectopia lens happens in the childhood. Adult patients without this sign difficultly will develop it. And patients with Marfan have been frequently reported also with severe myopia, with rapidly progressive, and we need to consider it in the criteria for diagnose, not only the ectopia lens. And sure, the cardiovascular features in Marfan syndrome is the main cause of morbidity and mortality. We have dilatation of aorta in the level of the valsalval sinus, and the type I aortic dissecations is the most common event in these patients. We do not see others types of dissecations in these patients. Predictive risk factors are hypertension, reduced aortic distendability, and aortic regurgitation. We need to avoid these risk factors and having a good control of this patient with therapy and lifestyle recommendation. But some patients will never develop severe aortic dilatation. However, aortic dilatation is very common find in these patients. Cardiovascular features in patients, pediatric patients, is not so common. The musculoskeletal finds is more common in this population. Here we have some images from cardiovascular features in Marfan, a typical pitch aneurysm, with a pitch morphology in the valsalva level, sinus level. And in the right, we have another histological pictures with different grades of progression of aortic degeneration, showing how the time of surgery is important in these patients, because when these patients have a very progress disease, we can't obtain good results with the aortic repair, because we have a histologic degeneration so marked. Well, it's important in the calculation of aortic diameter to consider the body surface area, but it's just to remember that adiposity is often reduced in younger Marfan patients. The body surface area calculated from standard normograms will underestimate the expected diameters of the proximal aorta and result in a higher Z-score. Of course, adults who gain age after skeletal maturity will appear to have an improved aortic Z-score. We consider that focus on the absolute diameter, its change, and its change is appropriate in this contours of Marfan syndrome. Several papers have reported Kaplan-Meier curves talking about risk factors and how it is important in the median in these patients. These survival curves with more than 500 patients shows like risk factor, the presence of more than one risk factor can be associated with a worse prognosis. And again, about the time of surgery, it's another study that we can see different prognosis comparing patients with elective repair of aorta and emergency repair, and we observe better prognosis in elective repair. So we have to need attention with these patients and close follow-up just to consider the timing of the surgery and not to lose this time that is essential for the success of the patient. Of course, that Marfan syndrome, we have the grand criteria. That's grand criteria. We have major criteria and minor criteria. Major criteria can be considered ectopia length and also the aortic dilatation. And we can see that in the absence of family history, sometimes the sequencing of the fibrillin gene, FBN1 gene, is very important to consider. Of course, that due to variable expressivity of these syndromes, Marfan syndrome, many patients with the suspicion of Marfan syndrome do not fulfill diagnostic criteria to clinical to Marfan syndrome. We have the systemic involvement, the systemic score, and with a lot of minor signs that suggest Marfan syndrome, and sometimes the patient had a low score, just suggesting Marfan syndrome or even differential diagnosis. About genetics, fibrillin-1 is the classic and the single gene consistently related with Marfan syndrome, with more than 1,000 causal genetic variants have been reported. Most of these variants are missense typing, affecting one of the specific motifs of the gene, and also conserved cysteine residues. And haploinsufficiency truncating variants may also contribute in this pathophysiological process. Genetic testing yield is about 90% of the case, maybe 95% of the case. And we don't know exactly how we do not identify variants in the other cases, maybe because we could have intronic variants or epigenetic process, but some variants in another genes related with other inherited aortic disease have been reported in patients with systemic score higher than 7 for Marfan syndrome, putting some question in this field. Marfan syndrome has autosomal dominant inherited pattern. It has an implication for familial genetic screening. We need to do the genetic screening and clinical screening of these patients, and the imaging assessment of these patients is very important. We need also to consider the clinical variability on the phenotype of these patients when we are looking for affected patients, not only considering the reports of our product that, yes, I have another case in my family or not. And about 25% of the cases of Marfan syndrome are caused by de novo mutations, so negative family history, like we see in the pedigree, the little pedigree at the right. So thinking in genetics, we need to talk about genotype-phenotype correlations. I think that in conclusion, in literature, we cannot do that. Exist really genotype-phenotype correlation for Marfan syndrome. But we have a lot of recent papers trying to do some considerations on this topic, especially considering different types of variants, not the localization of this variant across the gene. But we have, for example, this study published in Circulation comparing patients with haploinsufficiency variants versus dominant negative variants, and we can observe worse prognosis for the group of haploinsufficiency. This genotype-phenotype correlation is also associated with difference about gender, and we are need to advance in this field to really walk in this road that is personalized medicine. Some similar genotype-phenotype correlation was previously published in Nature. They identified that patients with haploinsufficiency mutations had an increased risk of cardiovascular death with a hazard ratio 2.5, and the combined endpoint of death and dissection 2.4, and for any aortic complication 1.6, compared with patients with dominant negative mutations. Of course, that we are talking about hard etiologies. We are living today a time in cardiology where the clinical trials have thousands of patients. And when we are talking about hard etiologies, heart disease, we have smaller cohorts, and this cohort have 357 patients, and the previous study that I have shown have a lot of some, I think that 500 patients. Well, other studies have tried to establish genotype-phenotype correlations in Marfan syndrome. I think that is not the point here to talk about scoliosis, but this is an association of premature truncating variants, PTVs, and is more associated with severe scoliosis than non-PTVs variants. And we think, starting from Marfan syndrome, we need to think in differential diagnosis, because we have other syndromic presentations for aortic disease. Several cases, we need to consider that several cases have only few syndromic manifestations. Sometimes a patient like this in the picture with borderline manifestations, not a very dysmorphic patient. Many times we can observe overlapping features with different aortic disease, and of course we need to think in this field with non-syndromic presentation, and that we will have only aortic disease, but with implications for familial management and screening. Next generation sequence panels are useful for molecular diagnosis, especially in this case, and to establish the differential diagnosis. Just to illustrate Loeys-Dietz syndrome, this is the main genes related, but we have other genes related with this phenotype. It's also an autosomal dominant inheritance pattern. We have also sinus valsalva aneurysm, but here other arterial aneurysm and especially tortuosities are observed. And the patients have also skeletal abnormalities, but some signs is typical of these patients in this context of aortic disease, like hypertaylorism and also bifid uvula or cleft palate. In the picture C here, you can see the bifid uvula that is a particular topic of this syndrome in aortic disease. Other syndrome, arterial tortuosity syndrome, is very rare. It's a recessive syndrome associated with GLUT10 gene variants, is a diagnosed differential of Lewis-Dietz syndrome because, like the name are saying, it has been reported with arterial tortuosis also. We need also a subtype of Ehlers-Danlos syndrome, the vascular type or type 4 of Ehlers-Danlos, caused by pathogenic variants in COL3A1 gene. The vascular type represents 5–10% of the case of Ehlers-Danlos syndrome. So it's a very rare presentation, but much more rare than Marfan syndrome or Lewis-Dietz syndrome. Aneurysm and spontaneous rupture of the medium-sized arteries are reported. We observe also organs rupture like uterus rupture or colonic rupture of these patients. And we have involvement of proximal and distal segments of the aortic arch, descendant thoracic aorta and abdominal aorta, as well as vertebral and carotid arteries. We are seeing that among these different syndromic presentations, we can have different segments of the aorta affected. So it's very important to consider in the management of these patients and the imaging accent. Other signs have been can help us to consider this phenotype. These patients have also high stature, but easy bruising, thin skin, and hyperextensibility of joints is present. In the vascular Ehlers-Danlos, it's not usually to see the hyperextensibility of the skin that is very common in Ehlers-Danlos syndrome. It's a nice slide that we can see different implications of this diagnosis for the radiological assessment. Like the first one is the pectus excavatum with aortic dilatation for Marfan. Also the severe dural ectasias that can be identified in these patients too. The Lewis-Dietz syndrome showing fusiform aneurysm disease in arteries other than aorta, and vascular Ehlers-Danlos syndrome with spontaneous aortic desiccation, not only of the ascending aorta, but with other segments of aorta. Well, other syndromes with aortic patches have been reported. Turner syndrome is not a high stature syndrome, it's a short stature syndrome with affecting females with infertility and non-development of sexual characters, but aortic dilatation should be investigated in these patients. Homocystinuria is a very similar phenotype or high stature phenotype with Marfan syndrome. We can observe in these patients myopia, ectopia lens, tall stature, but here these patients have an increased cardiovascular risk with thromboembolism and also coronary artery disease caused by pathogenic variants in CBS gene. Is a recessive disorder. Well, there's a phenotype that's osteogenesis imperfecta. Osteogenesis imperfecta will have several types of osteogenesis imperfecta. Some of these types, we need fractures in the neonatal period or even in the prenatal period with a strong deformation of the bones. But sometimes we we have patients with osteogenesis imperfecta type 1. It's a collagen pathy, a disease from collagen, and where the valve disease and aortic dilatation could be present in these patients, even in children or with the phenotyping progressing cardiovascular phenotype being diagnosed only in adult patients. And other signs that the cardiologist should be have in mind is the presence of osteoarthritis, like the aneurysm osteoarthritis syndrome, that is responsible about 2% of the familial cases, and that is caused by SMAD3 pathogenic variants. Other symptoms with aortic disease, we need to keep in mind that this phenotype is not only identified with the progression, the cardiovascular disease, not only with the progression of the disease in adult patients, but it can be present in children with like the neonatal Marfan sign. That's a very high presentation, caused especially by mutations in the exon 24 and 32 of the fibrillin gene, and it do differential diagnosis with contractural arachnodactyly syndrome causing by pathogenic variant in FBN2, not FBN1, not fibrillin 1, but fibrillin 2. It's the presence of arachnodactyly, sometimes not so marked. Contracture is different from arthrogryposis, but we can observe also deformity of the ears that is very marked in these patients. And another differential diagnosis with Marfan syndrome, that is the MES syndrome, that we do not have so marked aortic dilatation, but we have mitral valve prolapse, myopia, aortic skin and skeletal features. MES syndrome is an acronym for these features. And we have a borderline and non-progressive aortic dilatation in patients with high stature and also caused by mutations in fibrillin 1 gene. This is a table, a very interesting table, because we have the prevalence of these variants, and we can see here in Marfan syndrome a prevalence around 1 to 1 in 5,000, and the prevalence of aortic dilatation around 50% of the case, with the evolution to dissection to type I section, and around 1 until 12%, depending of the cohort. It's different of other syndromes like Lewis-Dietz, that we have a lower aortic prevalence around 20%, but the Lewis-Dietz syndromes, the mean age of first dissection seems to be lower than Marfan syndrome and the other aortic syndromes. And so we have here in Lewis-Dietz a more aggressive course of the disease. And well, below we will start to talk about non-syndromic inherited orthopathies, and we can see that non-syndromic heritable thoracic aortic disease, we have a lot of genes related with these conditions, and a prevalence that is variable among between different two cohorts, 9% or 46%, and the dissection could rise until 43% of these patients. But we have that many of these patients have been described with no aortic dilatations, suggesting incomplete penetrance, or that the penetrance of diseases could be related with cardiovascular risk factors such as hypertension or atherosclerotic disease. And in the patients with bicuspid aortic valve related aneurysm, we need to consider prevalence of 35% of aortic dilatation, but a very low level of dissection of aorta, just 0.1, 0.2%, because here we have a heart defect, not a connective tissue disorder. So the vascular tissue in these patients seems to be better, and it is related with the prognosis in this case. Talking about TAD, TAD is the acronym to familial thoracic aortic aneurysm and aortic dissection. So the case is like we call the case of non-syndromic aortic aneurysm dissections. Around 20% of the patients with aortic aneurysm have an affected first-degree relative. This variance, where the mean gene is ACTA2 variants, have been reported with autosomal dominant inheritance pattern, and it's important to consider that not only proximal aorta aneurysm have been reported, but aneurysm in all aorta segments, including cerebral aneurysms, can be present. These etiologies can be associated with heart defects like bicuspid aortic valve or coarctations. And it's important to consider the familial presentation in the patients with idiopathic aortic disease, because it has implications for the genetic and clinical screening for early identification of at-risk relatives. There are the recommendations from the ESC guidelines, the importance to evaluation of the family, to refer to the patient to a geneticist for family investigation and molecular testing, and the availability of age of onset warrants screening every 5 years for health at-risk relatives until diagnosis. I could like to remember, like I will say in the next slides, that the segment of this, the follow-up of this patient, the follow-up of these patients to health at-risk patients in 5 years would be reduced until 4 times by year in patients, for example, with Ehlers-Danlos time, suggesting a more close follow-up depending to the etiology, depending of the type of genetically triggered aortic disease. Implication of these syndromics or non-syndromics diagnosed for the imaging assessment, we can see here in the column at the right that we need to do a MRI in these patients, sometimes of whole thoracic aorta, sometimes of all segments of the aorta, sometimes thinking in arterial vessels from cerebrovascular to pelvis, like Lewis-Dietz syndrome, with a follow-up imaging at 6 months, and then annually to access growth rates with the same modality. Like I have said that in vascular Ehlers-Danlos syndrome, we have a lot of important clinical course of this patient with a high risk of rupture of this the vessels and all the organs. So we need to consider also a imaging study with a lot of vessels from cerebrovascular, heart, pelvis, abdomen, but also identify more close segments in these patients with more than one study by year. So when we are with a patient with a problem with suspicions with inherited aortic disease, we need to think in these other signs, extracardiac signs of the patient, thinking in the familial history, and when we suspect or not of a syndromic or not syndromic presentation, we can offer the genetic counseling for these patients, thinking that here in this flow chart, we have a difference in the genetic panel testing for syndromic or not syndromic approach of this case, with several genes related with a non-syndromic presentation and other genes related with syndromic presentation. Of course, that when we have a high suspicion of, for example, Marfan syndrome, we can request only the FBN1, the fibrillin gen 1 sequence. But in general, the available commercial genetic panels do not this division about non-syndromic and syndromic phenotypes. We have only ortho disease genetic panel involving all these genes related with syndromic or not syndromic presentations. And I think that is a positive point, because many of these patients with syndromic presentation sometimes have borderline presentations, and profession with no expertise in these morphological uses can misdiagnose these patients. So the genetic sequence has important value in this field. Management, we have targets for medical therapy depending of each syndrome, and also the counseling for pregnancy. We need to consider the woman that we need to be pregnant. We need to have a baby, and sometimes the time of surgery, including of these women, is important, because the time of surgery seems to be early in these women to avoid complications during the pregnancy. It's important. I think that's for the cardiologists and also to the cardiac surgeons. The time of surgery is central in this, in the reason to do a syndromic or not syndromic or a specific etiology diagnosis. And we have here that for Marfan syndrome, for bicuspid aortic valve, Lewis-Dietz syndrome, Turner syndrome, and even non-syndromic aortic thoracic aneurysm disease, we have different timing of surgery, and in general, it seems to be early than in the general population, that where we have 55% of aorta diameter. The last one in this table is Ehlers-Danlos syndrome. We need to do a consideration here that there is no specific recommendation, because they have a very thin vascular tissue, and spontaneous rupture is very common, including in in patients at very early age. On the other hand, Loeys-Dietz syndrome is not so aggressive than Ehlers-Danlos, but we need to consider also lower limits of aortic dilatation in these patients because they have been reported with early age of aortic dissecations. Well, sports recommendations for Marfan syndrome have been reported in the literature. I will not enter too much in this topic, but we need to see that, for example, with patients with no aortic dilatations, low and moderate static active is recommended. But when we start to have some aortic dilatation, we need to recommend only low dynamic activity. And when we have a moderate stage of the disease, avoid impact of sports, and also with the heart rhythm control is important in this patient. There are a lot of recommendations for each type of inherited aortic disease that have been reported in different guidelines. Final message, clinical cardiologists should mind syndromic signs, symptoms associated with inherited aortic disease. Genetic testing may be useful for borderline case, and it is recommended for familial screening and to establish the etiology and diagnose. Distinct genetic etiologies in inherited aortopathies are associated with different prognosis, management, including imaging assessment, pregnant, counseling, and time of surgery, and sports recommendation. So multidisciplinary care is relevant for the management and follow-up of these patients and family. I think that we need to also to consider it in front of a patient with aortic disease that we can have a familial or a syndromic presentation, and it's can change depending of the etiology, can change all the management, counseling, screening, and time of surgery of this patient. So the genetic testing and genetic investigation with multidisciplinary teams are very important in this context. Thanks for all. I will just to recommend at the end this recent editorial published by the Professor Arturo Evangelista and Gisela Teixeira from Barcelona, talking about the genetically triggered aortic disease outcomes on the long road to personalized medicine, published in JACC journal. It's a very interesting editorial that you can find at the web. Thank you for all.
Thank you very much, Professor Arsonval, for this enlightening presentation in an area that it's very important for clinicians, cardiologists, and also for the people who works with vascular and cardiovascular surgery. I have a couple of questions here, and the first of them, I will make you a question. The fibrillin 1 gene in Marfan syndrome, there are 65 exons described. I read once an important paper in 2007 regarding prognosis for major cardiovascular events, transplantation, rupture, death, and so on. What do you think about Kaplan-Meier curves in Marfan syndrome according to the mutation that you find in that specific axon?
Well, I think that when we are talking about heart disease, the main challenge is the number of patients. When we get, for example, that 2 studies that I have present before, considering all the exons, when they are grouped around 300, 500 patients with Marfan syndrome or with aortic disease. So what we will talk about a specific exon to really have evidence to do a genotype-phenotype correlation to identify worse prognosis in a little or for a very small cohort, and how it could implicate in my clinical making decision process. It's very challenging. So I think that now we have more information than 5 years ago or 10 years ago. It's a science that are evolving all the time, and sometimes we have that things in mind that in families with truncating variants, for example, and that took variants that cause haploinsufficiency in fibrillin 1 could be have a worse prognosis, but how is it could be really changing my practice in my day of practice. It's sometimes we have some doubts on it. I think that the importance is to establish the genetic diagnosis of these patients, because if the prognosis will be worse or not with the variant type, we will have a different management of these patients according is the diagnosis. Sorry.
Okay, taking your message for me, I wonder that it's important to point out we are dealing with a rare disease, and rare diseases, Marfan is 1 to 10,000, 20,000 individuals. So the prevalence, the frequency. So they are rare diseases. We are not used to see in the shopping center one guy with Marfan. So you are right. But I wonder that these cohorts are growing, and then the Kaplan-Meier curves will be more accurate to decide how soon we need to intervene with a surgery or not. I agree. I fully agree with you, Arsonval. There is a question from Dr. João Ernesto Piccoli. Good morning. What's your opinion about the use of angiotensin receptor blockers for attenuation of TGF beta signalizing?
Well, João Ernesto Piccoli. Well, I do not have contact with any specific trial about it. If you need to put something more on it, you can write here. Maybe Ricardo or my colleagues have some considerations on it. But about this specific pathway of TGF beta, I don't know if regarding it, I don't know exactly if this medical therapy would have some implication in this specific pathway. Sorry.
I am with you. I am not aware exactly about the pathway, but I think that this TGF beta maybe is more related with Loeys-Dietz disease than with Marfan. I'm not sure. Martin, do you have any thought about this?
I think it's an interesting question, because angiotensin II blockers is some of the medication that are indicated in patients with aortic dilatation, and syndromic and non-syndromic. but also beta blockers. So in the little number of patients that I have with aortic dilatation and genetic study, and they are usually young patients that do not tolerate medication because of hypotension. So you have to choose between beta blockers or angiotensin II blockers. I try to use both to my
Practice.
yes, but if the patient have aortic dilatation, I have no doubt that you have to use beta blockers, and if the arterial tension allows you, also gives the patient angiotensin II blockers. My big question is if you have to give to genotype positive, phenotype negative family members, because if you think that angiotensin II blocker is a medicine that is acting, preventing an abnormal signalization in the tissue of the wall of the artery, perhaps this patient with younger teenager with a positive mutation that is a clear pathogenic mutation, if you act early in this way, but there is nothing published about that. And I asked to Gisela Teixidó and Arturo Evangelista, and there is no enough information to use in this patient.
The fact is, we as a clinician, the idea, and from my point of view, is as low as you support, the best. So beta blockers and these kind of medications, besides any other kind of pathway they act, they may low blood pressure. Then this is important in the context of these diseases. Mm-hmm. So I thanks Dr. Piccoli from Universidade de Buenos Aires, UBA.
I think that in this point, as Martin has commented, the beta blockers or angiotensin receptor blockers being also two options for all this disease. We have some papers talking more specifically about MAFON patients. Of course, the more studies signed, but about TGF-beta, about Louis G. Sandwich, John Wansi sent us this article or something is more later. I think that sometimes the angiotensin receptor blockers is more accepted in vascular Ehlers-Danlos or Ehlers-Danlos patients, because these patients have more dysautonomy, changing the pressure, and sometimes they do not tolerate the beta blockers. It could be an option in this context.
Mm-hmm. So it's 10:33 Brasilia time, also in Argentina, but we must go on. And the next speaker is Professor Martin Ortiz, and we will not do an interval now, and we will follow with Professor Martins, who is from Rosario, Argentina. He's a cardiologist specializing in heart cardiovascular diseases, clinical advisor of Health in Code, Coruña, Spain. And Professor Martin, you can put your presentation on the screen. He will deal with the topic arrhythmogenic cardiomyopathy. Again, as I mentioned to Professor Arsonval, be my guest.
Okay. I am trying to share my screen. Oh, I have a problem here. Excuse me.
No problem at all. we are among friends, and this is a very informal symposium.
There is a privacy question here that is saying that the token is have been.
If there is a problem, you can send. Ele pode mandar para nós, se for, e nós botamos a apresentação e pode mandar para cá. If you have problem, you can send to me.
I trying to solve it.
Great.
Wait a minute. In my preferences of the system, it's a question of privacy because you are saving the presentation. So
No hurry, no hurry. We are good.
Let me know.
Meanwhile, we can say that to the audience that cardiovascular genetics is a subspecialty that is inverted commas, rolled. There are plenty of things that we already know, but I think the presenters, the speakers agree with me that there are much more to be found. So some things are in a gray zone, some things are already unknown, and as I mentioned before, in every fascicle of European Heart Journal, JACC, Circulation, and other cardiological papers, always there is at least one paper, one manuscript regarding the issue. And in 2022, it's been difficult to follow how many informations we got from the literature. For example, I work with sports and exercise cardiology. And this year, we had a guideline, not a guideline, a position paper from the European Society of Cardiology. Silvia Castelletti is the first author, and Mike Papadak is the senior author regarding sports and genetics. And so Arsonval maybe agree with me that it's been difficult to follow all the information. And this is why when there is a compilation of information in a symposium like this, we can get pinpoint information from Arsonval regarding arthropathies, from Juan Pablo Shoa regarding Noncompaction and dilated cardiomyopathy. And now Martin will talk about arrhythmogenic cardiomyopathy that can overlap with other genetic familial diseases in cardiology. What do you think about this, Arsonval?
Well, I hope that in Brazil, I have lived in Spain by 6 years. There is the web of collaborator hospital is very significant.
Can you open your camera, please?
Sorry, just a second.
Martin, you can answer. You can answer the question, please.
No, I think that just to finish, I think Ricardo, that in this symposium we can become more strong. Our network here in Brazil with other colleagues around the world to better understand these disorders, to be updating all this information, like you say, because it's very difficult, and we really need of a critical body of scientists, of colleagues, to interpret all of this information and to do it more useful for the lives of our patients.
This is the most important message that the network that you are doing And actually, today in Niterói, Rio de Janeiro, there is another Congress in genetics. So you can see in the same day, at the same time, two different congresses in this area of knowledge. They are dealing with amyloidosis. We are dealing with a whole bunch of subjects. And for sure, next week, December the 3rd, probably the people who are there will be with us. But so Professor Martin Ortiz Genga will give us a lecture regarding arrhythmogenic cardiomyopathy. Again, as I mentioned before, please be my guest, Professor Martin.
Thank you, Ricardo. Sorry for the inconveniences. It's a pleasure for me to share this space with friends and very good persons. My talk is an actualization about arrhythmogenic cardiomyopathy, centered in genetic, but also a review of all the disease by clinicians. So arrhythmogenic cardiomyopathy is a well-defined, is one of the type of well-defined primary cardiomyopathies recognized in worldwide scientific association, and it's a primary and inherited myocardial affection with prevalence varies between 1 in 1,000 and 1 in 5,000. It's characterized by a progressive fibrofatty infiltration of the myocardium, like an infiltration, and that and other changes lead to the particular predisposition to ventricular arrhythmia and early sudden cardiac death. This is a very changing and evolving disease, and we can see this in the evolution of the name of the pathology, because in the first years, scientists think that this was a congenital disease, and think that this was part of the whole anomaly, and then they use the term dysplasia to describe the tissue changes in the right ventricular wall, but then realize that in fact it's not a real dysplasia, and then they adopt the term arrhythmogenic right ventricular cardiomyopathy. But then they realize also that there is not a affection only of the right ventricle, but also left ventricle could be affected, or both, and they name right ventricular or left ventricular cardiomyopathy, and now it's a tendency to name the disease as arrhythmogenic cardiomyopathy as a whole. The etiology and the genetic substrate become to us by the discovering of two particular diseases in the early millennium. One of them was made by the Professor Protonotarios in the Naxos Island in Greece, and they describe particular families with a cardiovascular syndrome that presented with woolly hair and palmoplantar keratoderma, and also with right ventricular dilatation and arrhythmia, which follows an autosomal recessive pattern of inheritance. At the same time, and in Ecuador, Dr. Carvajal Huertas described a very similar syndrome, which is also characterized by woolly hair, palmoplantar keratoderma, but in this case, dilated cardiomyopathy with a predilection for left ventricular dilatation and dysfunction, and also with the autosomal recessive pattern of inheritance. This gives the clue to discover genetic substrate of the disease and to discover that this arrhythmogenic cardiomyopathy is a desmosomal disease, and the cellular unit that is affected is this particular structure that is in the intercalated disc, that is the portion of the where the cell connect with each other, and that acts as an anchoring and structural anchoring between cells. And this desmosomal structure is formed by different proteins. Some of them are transmembrane, and some of them are intracytoplasmatic that connect one cell with the contiguous cell. So the pathophysiology is that mutation in these desmosomal proteins can give an impaired desmosomal assembly, and this affects the myocyte attachment and goes to cardiac dysfunction. But another way describe it is that one of these proteins, that is placoglobin, suffer a translocation to the nucleus and active Wnt signaling that predisposes to the progenitor cell, to the cardiac progenitor cells, to go to fibroadiposes instead of mature cardiac myocytes. But also, besides these structural and tissue changes and abnormality, we must recognize that in the intercalated disc, the desmosomal junction is in this portion in close relationship with other structures, especially gap junctions and sodium channels, and this give the clue that perhaps the electrical couple between cells is affected earlier than the structural attachment between cells. And this could explain the particular clinical course of the disease with the concealed phase, where structural alterations are absent, but the patient is equally exposed to ventricular arrhythmias, and where the diagnostic criteria have limited usefulness to detect and to diagnose the disease. So this is important to take in mind that patients with arrhythmogenic cardiomyopathy could present with ventricular arrhythmia or inclusive with sudden cardiac death with minimal or no structural heart disease. And when we perform genetic study in this patient, we go first to the desmosomal gene mutation in the 5 described genes, placoglobin, desmocolin 2, desmoglein 2, desmoplakin, and plakophilin 2, and we have a rentability that is nearly 50% for this patient. But we then discover another non-desmosomal form of the disease that explain nearly 20 or 30% of the disease, and we could see some example of them, but they include phospholamban, TMEM43, titin, TGF-beta3, desmin, which is an important gene in the differential diagnosis of arrhythmogenic cardiomyopathy. And this was said some years ago. Some investigations have the theory that arrhythmogenic cardiomyopathy was the more polygenic diseases in inherited cardiovascular disease, because they found that as many as 48% of patients who have the diagnosis of the disease have at least 2 different genetic mutations, and these people with 2 mutations usually have more severe signs of the disease. But I think that this is not really true, because the genetic noise of this gene is particularly high. That means that the probability of found a rare variant in general population or including controls is nearly 16%. So especially if we're talking about missense mutation. If we talk about radical mutation, those mutations that produces a premature truncation or altered splicing, the prevalence of this variant in general or in control population is minimal. So many of those patients that are think to have 2 mutations that are 2 hits given to the phenotype, I think that is not so high, and the percentage of patients with the rhythmogenic cardiomyopathy we have multiple mutation is close to other cardiomyopathy, between 5 and 10%. And talking about another desmosomal gene, I think that this was a discovery in 2008 in Newfoundland and Island of Canada, of a particular mutation in TMEM43 with a founder effect in that region that demonstrate a very aggressive arrhythmogenic right ventricular cardiomyopathy, especially in men, given to not only arrhythmia, but also to dilatation and heart failure. And another example of a very important desmosomal gene is something that Dr. Ochoa commented previously for Lambam, this particular mutation, which is a founder effect in Netherlands, which is also associated with early sudden death. Perhaps the first mutation where low voltages in leads are described, as you see in this particular ECG, where left ventricular late gadolinium enhancement is seen, and this goes to a phenotype that overlapped with DCM and also biventricular arrhythmogenic cardiomyopathy. Regarding the clinical criteria to diagnosis arrhythmogenic right ventricular cardiomyopathy is not easy. The scientific societies make an original TAG4 criteria in 1994, and then they revised this criteria, and the most significant changes was made in the definition of the structural abnormalities and the addition of the identification of a pathogenic mutation as a major criteria. But as a resume, diagnostic criteria are centered in familial and genetic aspect, in electrocardiographic, which is a very important tool to diagnose these patients, especially in previous to the structural alteration, the presentation of the arrhythmias, the structural alteration, as I say, and the tissue characterization. But then we realize that many patients do not have only right ventricular abnormalities, and that more than 80% present left ventricular compromise also. So the descriptions of arrhythmogenic left ventricular cardiomyopathy start to be published, especially with desmoplakin truncating variants that leads to this particular phenotype. Also, low voltages on ECG, a particular lineal subepicardial or intramyocardial late gadolinium enhancement, especially in the left ventricle, and many times without left ventricular dilatation and without left ventricular systolic dysfunction. And another genes was discovered, like truncated mutation in filamin C, that are also associated with an overlapping phenotype between arrhythmogenic left ventricular cardiomyopathy and dilated cardiomyopathy. And the ECG is very similar to the previous one in desmoplakin, low voltages ECG in QRS voltages in lip lens, very subtle repolarization abnormality in laterals and left precordial leads, with this particular circumferential fibrosis in subepicardial and intramyocardial tissue, especially and mainly confined to the left ventricle. And most of the patients without, as I say, left ventricular dilatation and left ventricular systolic dysfunction. And this disease, the filamin C truncation variant, also affects weakens the myocyte adhesion because of the participation of this particular protein in intercalated disc. In the recent years, in my opinion, two very important expert consensus statement was published, this one in 2019 and the other one in 2020, trying to clarify the diagnosis, the management, and the risk stratification of arrhythmogenic cardiomyopathy, especially when we found that the disease is not confined to the right ventricle. So this first per consensus, I think that give us a very important review about the genetic and pathways that take part in the different forms of arrhythmogenic cardiomyopathy, saying that desmosomal genes are most prevalent in arrhythmogenic right ventricular cardiomyopathy, especially in plakophilin 2 mutation, but instead desmoplakin is more frequent in left ventricular arrhythmogenic cardiomyopathy. Phospholamban, as I say, could give a biventricular affection. But some concerns about these guidelines gives to me some doubts. One of these is that ventricular dysfunction seems to be a condition sine qua non, which I think that is not true, because some patients with arrhythmogenic cardiomyopathy could present without ventricular dysfunction. The other one is the definition of the arrhythmia in the clinical presentation. It is true that ventricular arrhythmia is one of the criteria, but there is not a sine qua non criteria, and perhaps more doubtful is when they define the type of arrhythmia. They put ventricular arrhythmia, but also atrial arrhythmia and cardiac conduction disease. For me, it's a little confusing that, and the other including some other diseases like sarcoidosis, myocarditis, amyloidosis, Chagas disease, that make a little confusing, including Fabry disease or the end-stage hypertrophic cardiomyopathy. That is the part that is confused to me in this guideline. But I think that it's very clarifying in several other aspects that I will in the talk. Another expert consensus that I consider that is very important is the publication of the Padua criteria. I think that this consensus is very clarifying for me in how to define the diagnosis of arrhythmogenic cardiomyopathy and the different types of structural alteration that this disease could have. They are based on electrocardiographical alteration, structural alteration, tissue characterization, but mainly by the use of late gadolinium enhancement and genetic. And then define three types of ventricular arrhythmogenic cardiomyopathy. One is the dominant right, where the morphofunctional criteria are confined to the right ventricle, and there is no affection of no structural affection of the left ventricle. One is biventricular, when we found left ventricular affection, and one is the dominant left, where the genetic is very important because you have to have left ventricular structural criteria plus an arrhythmogenic cardiomyopathy gene mutation. That means a causal mutation in a gene that have been previously linked to arrhythmogenic left ventricular cardiomyopathy. And this is the same consensus, showing that cardiac magnetic resonance and molecular genetic testing is fundamental, besides the family history, the arrhythmia, the ECG, the ventricular arrhythmia, and the images of the structural disease. Regarding risk stratification, I also show you two important papers that have been recently published about how to stratify this patient, especially patient with arrhythmogenic right ventricular cardiomyopathy, in order to decide the implantation of an ICD. Both papers are multi-center, Center for America and Europe, and they collect an important number of patients. And the first ones was published in 2019. They included patients with an established diagnosis of arrhythmogenic right ventricular cardiomyopathy without a previous ventricular arrhythmia episode at baseline. They construct a model for individualized prediction of any incident sustained ventricular arrhythmia. The event rate was 5.6% per year, but only 36% of these events were life-threatening ventricular arrhythmia. Some of them was sustained ventricular tachycardia without hemodynamic instability. They found in the multivariate analysis 7 factors: male sex, younger age at diagnosis, recent syncope in the previous 6 months, non-sustained ventricular tachycardia, logarithmically the prevalence of premature ventricular complex in 24-hour Holter, the number of negative T waves in basal ECG, and the right ventricular ejection fraction, and create a formula, a model to establish the 5-year risk for these arrhythmias that function very well and demonstrated that a 20% reduction of ICD placement with the same proportion of protected patients compared with the previous International Task Force criteria of 2015. And the other important publication in risk stratification by the same group tried to study only the potentially fatal ventricular arrhythmia and sudden cardiac death, because the endpoint of the previous paper may have some problems to make to estimate the real risk of sudden death. And they included patients with and without a history of sustained ventricular arrhythmia diagnosis, and the event rate was 1.5% per year. The first interesting discovery was that patients had the same probability of life-threatening ventricular arrhythmia independent of if they had a prior event or not. There is also no differences if this prior event was an unstable or a stable ventricular tachycardia. But the recurrences of any sustained ventricular arrhythmia was different and was much higher in those patients with prior ventricular arrhythmia, being more than 50% at 5 years. And in the multivariate analysis, they found 4 factors that are significant: male sex, younger age at diagnosis, the prevalence of premature ventricular complex, and the negative T waves. And they also give an estimated risk, an estimated number of defibrillators that we have to put in any cutoff of risk stratification. So these are the criteria for establishing both events, life-threatening ventricular arrhythmia, but also any kind of ventricular arrhythmia. And we have an online calculator to introduce the particular characteristic of the patient and to have this percentage of risk. What happened with risk stratification in left ventricular arrhythmogenic cardiomyopathy? Well, this is well established in the consensus of 2019. there are some particular mutations, for example, phospholamban, filamin C, or laminin C, that with a left ventricular ejection fraction minor than 45%, a recommendation class 2A is given for putting a defibrillator. Perhaps some genes like truncating variant in desmoplakin or desmin mutation associated with left ventricular arrhythmogenic cardiomyopathy could also be included in this group. And another important task in people with arrhythmogenic cardiomyopathy is the influence of an environmental factor such as endurance exercise. This is one of the first papers, but there is a lot clearly demonstrating that the endurance exercise not only predisposed to genetically positive patients to develop the phenotypes, but also those patients who develop the phenotype have a higher risk to present ventricular arrhythmia and systolic dysfunction and heart failure. So the guidelines made a recommendation to genotype positive family member without the phenotype to avoid endurance physical activity in order to prevent the phenotype development and to prevent severe phenotype. What happened with arrhythmogenic left ventricular cardiomyopathy? There is no specific recommendation about the sport, but I think that in the future we will go for the same way that in arrhythmogenic right ventricular cardiomyopathy. My final remarks are that this disease, arrhythmogenic cardiomyopathy, is a continuously evolving disease, that the diagnostic criteria are improving accuracy for especially early and concealed stages and those cases with left ventricular compromise and affection, that the etiology and the genetic substrate, we have to think in arrhythmogenic right ventricular cardiomyopathy that the more than 95% are desmosomal gene, instead of arrhythmogenic left ventricular cardiomyopathy, where desmosomal and other non-desmosomal genes are most equally in prevalence, that arrhythmogenic cardiomyopathy is the inherited cardiac condition where perhaps are more important lifestyle modification, and that risk that we are giving more accuracy to risk stratification with the help of genetic in some cases. And finally, that if we continue investigating the pathophysiology and the pathway to give the disease, to find a treatment to reverse this particular condition. So thank you very much for your time and for your invitation. It was a pleasure for me.
Thank you very much, Professor Ortiz. It was a great presentation as usual, and at this time in English. So I never heard you before in English, and it was very nice as in Spanish and in Portuñol. So we have 20 minutes for questions, and I have the pleasure to say to the audience that I have with me Professor Peter van Tintelen, and he is an expert also in arrhythmogenic cardiomyopathy, and maybe he will be able to participate in the discussion part of the presentation. But I would like to ask you a question, Martin. Although the literature say that this disease, the prevalence is 1 to 2,000, I count in my hand the numbers of patients with this disease I had seen in my life. So for me, it's a rare disease, a very rare disease. And you showed something about endurance athletes. And as a sports cardiologist, when the diagnosis of this disease is made in an athlete, it's a big problem. And the literature, there is a consensus that endurance exercise, long duration exercise, is forbidden for these guys because they die. But when you put the defibrillator, when you indicate the defibrillator, it's okay to continue to play. We have in the World Cup two individuals, two athletes playing with a defibrillator. Ericsson from Denmark and Blind from Holland, from Netherlands. And I don't know in depth their cases, but in terms of this disease specifically discussing, what do you think? Would you be comfortable to indicate a defibrillator, to insert a defibrillator, and to let the athlete to play or to cycle or to whatever?
Well, I think we are talking about endurance athlete, and I would be not comfortable at
Why?
all. I am not the most experienced physician to say this, especially with Dr. Van Tittelen in the round table. But I think that the defibrillator prevents you from ventricular arrhythmias. But it is also demonstrated, and I also think in this line, that the predisposition to left or right ventricular dysfunction with the sports in a high intensity is also demonstrated. So I don't know. My position would be put the defibrillator if the patient have a significant risk, as I say, because it is also true that the arrhythmias in arrhythmogenic right ventricular cardiomyopathy are sometimes stable and monomorphic ventricular tachycardia, that they are not an equal indicator of sudden death, but the machine could have some anti-tachycardia pacing or some kind of application that could lead to the patient not to degenerate in ventricular fibrillation. So my opinion is that atherosclerotic cardiomyopathy is the cardiomyopathy that you have to stop endurance activity. But this is my vision.
Okay, let me be dogmatic. I agree 100%. For me, the disease, the substratum is over there. So you treat arrhythmias, but you don't treat the disease with the defibrillator. And Martin, if you let me ask Professor Van Tittelen, what do you think about this?
Yeah, well, it's a great issue, and while you were mentioning Danny Blind, the soccer player from Amsterdam, I all of a sudden realized that in the Dutch first division, containing, I don't know, 24 teams times, let's say 20 players. So you're talking about roughly 500 professional athletes. Already in the Netherlands, there are about between 10 and 12 professional soccer players that do have an ICD. So the numbers are impressive. Well, what is very important nowadays is this kind of joint decision making. So basically, you discuss with the patient, or in this case, the professional athlete, what the pros and cons are of continuing sports, and also you have to take into account the local rules and regulations. I think Ericsson is a great example because he was not allowed to play in Italy, where the rules are more strict, and he moved back to the United Kingdom, where he is allowed to play. But again, I fully agree with the two of you that we know that extensive exercise, and that's what professional athletes do, is a risk factor for more severe progression of disease. So from that point of view, it's not wise to continue active sports. And also in Belgium, we do have this great example, and that was actually a soccer player.
No. We can hear you.
Yeah?
Okay. Yeah, now, yes.
Okay.
So in Belgium, we have... No, again. No problem. We have plenty of time. Feel comfortable, and we can hear you.
Okay.
No. I think it's a microphone problem.
Yeah, the Bluetooth connection.
Yes. Can you hear us? No. Any question, Professor Thais?
Yeah, I have one.
You can ask a question to Professor Martin, and then Professor Van Tintelen is fixing everything over there in Utrecht.
Okay, well, my question is about mutation carriers, especially young people, like first-degree family members, like the two genotypes, like 12-year-olds that don't have the phenotype expressed yet, and we don't know if they're going to express it or not. Is there any exercise restriction for these patients? Or because, well, we don't know if they're going to develop it, you know, so how does it work with it?
Yes, I think it's a very difficult task because we are facing with childs or teenagers that harboring, we are talking about clearly pathogenic mutation, of course. I really think that exercise could modify the clinical presentation of the disease. And we are talking about mutation that although we are talking about a clearly pathogenic mutation, truncation in plakophilin 2, truncation in desmoplakin, we usually saw families with very different penetrance. And we usually saw patients who are carriers of the mutation, and they are in their 60s or 70s, and they have no sign of the disease. So I really think that arrhythmogenic cardiomyopathy is where environmental factors could have a very important role. So in these people, I try to say that perhaps is better that they do not enroll in those sports that requires a very high endurance activity, but of course the recreational sport is allowed and is necessary for children and for teenagers, but it's difficult to put a limit in these cases. It's a very difficult task, but I make my higher effort to convince them in try to orient their lives and trying to not to give professional cyclists or enroll in 42 marathons activity or something like that.
Very good. We were with Professor Van Tintelen, and he was talking about cases of professional soccer players in the Netherlands and Belgium, and there is a case in Belgium with a disease. No.
Yeah, we still can't hear you.
We can't. Okay, we can go through making questions to Martin, and you can try to fix, no problem at all. It will be a problem if in your lecture, but now it's not a problem. Martin, again, exercise and this disease, arrhythmogenic cardiomyopathy. We have to deal very deeply in these cases as we are talking right now, and the answer that you gave to Dr. Thais is clear. Besides the fact that, do you think that genetics, it has a prognostic importance, and how important is to make a genetic test when you make a phenotypic diagnosis of this disease? Because you show us that even right ventricle, the desmosomic mutations, and nowadays, maybe higher in the future, the 5% of the exclusive left ventricle mutations, they can be very, very dangerous for the individual who carry the mutations. But is it important and fundamental to do genetic test in Rosario, Argentina, for example?
Yeah, I think that I like to split arrhythmogenic right ventricular cardiomyopathy and arrhythmogenic left ventricular cardiomyopathy. I think that in arrhythmogenic right ventricular cardiomyopathy, genetic study could be important for the diagnosis, especially because sometimes we have limited criteria, and if we have a patient with negative right precordial T waves and some kind of right ventricular abnormalities in the MRI, and you found a clearly pathogenic mutation in the desmosomal gene, you are establishing the diagnosis. So, but not in risk stratification from my point of view. You can see in the predictor that the kind of the mutation is not considered in the risk stratification of arrhythmogenic right ventricular cardiomyopathy. Instead, in arrhythmogenic left ventricular cardiomyopathy, I think that you have a patient that have low voltages on ECG and near or near normal or normal left ventricular function, and you found this circumferential leg gadolinium enhancement, and you found a truncation in desmoplakin or a truncation in filament C, perhaps is another tool to make a decision to the implantation of an ICD early than the left ventricular dysfunction starts. So this is my point of view regarding genetic and diagnosis and prognosis.
And for sure, also for cascade study, to study the.
No, of course.
Yeah. Okay. Professor Peter, Professor.
Yeah.
Oh, you are with us. Great.
Okay, I'm so happy.
No problem.
No, I just wanted to mention that there's this impressive case in professional soccer in Belgium, where one of the players with a diagnosis of ARVC also has an ICD. And you see this movie, and I can share it with you because it's on YouTube, that he loses consciousness, and you see his ICD firing, and basically he regains consciousness, and the story is that he wants to continue playing this game. But that's a very impressive example of what an ICD does. But again, professional high intensity sports like soccer and bicycling, those are not real games that are good for if you do have a arrhythmogenic right ventricular cardiomyopathy. And if I may, Ricardo, comment on the role of genetic testing. So of course, I fully agree. It's important to make a diagnosis because it's in the criteria. It's important for family screening. But one other thing is that nowadays, and I'm part of that initiative, we are working on risk calculator tools based upon genetics. So we are working on a desmoplakin risk calculator. Of course, we already have the ARVC risk calculators, but that's based on a diagnosis. But we're moving towards a PKP2 risk calculator, desmoplakin risk calculator. In the Netherlands, we do have one specific mutation in phospholamban that gives more or less a biventricular arrhythmogenic cardiomyopathy. And we built a special risk calculator just for that single mutation. So I definitely think we are moving from disease-associated risk calculators to gene-associated risk calculators, and in some examples even to mutation-specific risk calculators.
Perfect. Returning to the Belgium example and the sharing decision process, I don't know Latin, I don't know this language, but I know one sentence. Primum non nocere. This is very important for me, and this is the case that sometimes we can't do a sharing decision process because we are doctors and we know technically what is going on. For me, if this happened and I am the physician and the person decides free will, I will still continue. I will not be his doctor anymore. And we will put in the file, look, my idea is this. I think that sometimes the sharing decision process must be rethink, because it can be a way to just do this with the patient. Oh, it's a sharing decision, so it's okay. It's not everything okay, every time okay. Well, Thais, any other question to Martin, the audience?
I have a question to Professor Van Tittelen.
Great.
Regarding your last comment, because the last paper I comment on risk stratification that you participate, that I found amazing too, but you are not defining a particular cutoff of percentage. So in your experience, when you consider that the risk is sufficient, because my idea is that it's between 10% perhaps, but I found a sentence in the paper that saying if you consider all the whole cohort of arrhythmogenic cardiomyopathy, the 5-year risk if 5% is much higher than other cardiomyopathy, so all patients must deserve a defibrillator. But in your experience, what you consider that is a good cutoff to decide implantation?
Yeah, again, this is a great question and a great point for discussion. It's of course finding the balance between not losing your patients to sudden cardiac death because of not implanting an ICD versus the harm an ICD can do versus implanting an ICD that never fires. And our cutoff values nowadays are closer to 5% as compared to the 10% that you mentioned. But we also keep in mind that the risk calculators that we have developed not always take into account specific abnormalities on MRI, for example. You mentioned fibrosis on MRI. We're getting more and more to the point that we have to weigh some abnormalities on subtle abnormalities on MRI as well. So it's a moving target, and sometimes we weigh additional signs and symptoms that are not always in the known criteria or risk calculators. But again, it's a huge challenge.
Yeah.
And again, those risk calculators are only, a way to support you, and it's not a clear yes or no.
Thank you very much. Last and very short, do you have any preferences of the type of beta blocker that you use in arrhythmogenic? Do you see any differences? Nadolol is better than others?
Oh, I'm not a clinical cardiologist, so I'm a clinical geneticist, and I'm part of the of course part of the cardiogenetic team, but I'm not every day into outpatient clinic prescribing the drugs or whatever. So I cannot share my personal experience on that.
Okay, no problem. Thank you.
Okay, it's 11:30 sharp, and before moving to the next speaker, Professor Peter Van Tintem, I would like to say that it's a big honor for me to be here after this gorgeous talk from my friend Martin Ortiz, and also I must say that it's amazing to be in a symposium with professors as Professor Van Tintelen and Martin Ortiz. Martin Ortiz is the leader author of the 2016 JACC paper in truncating filament C, and Professor Peter Van Tintelen is one of the authors of the consensus of the European I don't remember exactly if the heart rhythm or the European Society of Cardiology consensus and arrhythmogenic
Heart rhythm.
Heart rhythm and arrhythmogenic cardiomyopathy. So people who are doing science, they are with us, and also we are with Dr. Thais Beuren, who is the person who will be writing the consensus in the future. I am quite sure. So I am delighted to be here. I will ask you for 1 minute, and we will have our last lecture with Professor Peter Van Tintelen regarding hypertrophic cardiomyopathy. Just 1 minute to go to the toilet, to the shower, no, to the restroom, and to have a glass of water. And in 1 minute, we will be with you. Thank you.
Yep. Beautiful.
Good afternoon, good morning. Here in Brazil, it's 11:39 Brasilia time. We are having some technical problems and we are fixing them. In a few minutes, we will start the last presentation of this Saturday. I would like to invite you to be with us next Saturday, 8:30 Brasilia time. We will deal with some other subjects, for example, cardiomyopathies. Dr. Luciana Sacilotto will be dealing with 8:30. Then Dr. Jorge Garrido from Coruña will talk about some other cardiomyopathies. And then we'll have Diego Garcia talking about dyslipidemias and genetics. And the final talk will be held by Dr. Natalia Patterson-Sonisheva from San Francisco, United States. And she will talking about genetic gene therapy in some familial cardiological diseases. So we'll have another amazing morning in a week. We are trying to have the presentation on, and if you want to make some questions to us regarding the previous presentations, feel free, and because I am stomach trying to no problem, Thais? No. Não recebeu e-mail? She didn't get your email with the presentation.
No, I will try to send it by regular mail, but
good.
Probably too large, but we'll see what happens.
No problem. Since this is an informal but a very serious meeting, I think you understand that this kind of things happen, and in the last 3 years we had some technical problems while participating in online presentations, and this is not a real problem. It's just people.
Now we can be happy that we are able to share people from all around the world in online events nowadays. So we're just starting to have some experience with it. It's I think it's expected.
Otherwise, I can try what Martin just proposed. Let me see.
Your microphone, Martin.
When I try to share my screen, a pop-up says me that the system need your authorization, and so you go to system preferences and have several.
Martin, thank you very much for your help, but Thais just got the presentation from Peter, and so I'm more than happy to present Professor Peter Van Tintelen. He's head of department and clinical geneticist and genetics at the University Medical Center Utrecht, in Utrecht, the Netherlands. Professor Peter is very humble. I'm sure that he has much more titles to give to us, but there is another one that I will mention, that he is with me, the advisor of Dr. Thais Mariel Andara Beuren in her PhD. So everything is done. Professor Van Tintelen, be my guest.
Yeah, well, thank you very much for this kind introduction, and again, for me it's very exciting to present here. And what you just mentioned, Ricardo, it's, well, one very important thing is to hand over our knowledge and experience to the next generation of people, and sharing the things that we have learned over the years. So if I can move to the next slide. The main focus of my presentation will be on clinical and genetic aspects. And the reason is, well, first of all, because I'm not a clinical cardiologist, and a lot of beautiful guidelines have been presented on what to do, what signs and symptoms are that are important in hypertrophic cardiomyopathy. So my main focus will be on clinical genetics. If we can move to the next. And another reason why I thought this was an important approach was a survey that was done among Dutch cardiologists, and several hundreds of them answered to this survey on risk stratification in hypertrophic cardiomyopathy. Can I get the next one? And what they said about themselves, well, nearly 2/3 of cardiologists said that their knowledge on hypertrophic cardiomyopathy was either poor or even very poor. And if you take a look at the numbers of patients that they saw with hypertrophic cardiomyopathy, it was only a handful. So 58% had 5 patients or less with hypertrophic cardiomyopathy, and 82% only had less than 5 individuals who didn't have any signs or symptoms yet. And what the cardiologist answered, 95% of them thought that regular education courses about hypertrophic cardiomyopathy and genetics are valuable. And that's, well, another reason why I like to present these data here. Can I move to the next one? Well, as you all know, hypertrophic cardiomyopathy is one of the main types of cardiomyopathy. Can be familial, can be non-familial. If you can go to the next one, roughly 70% of hypertrophic cardiomyopathy patients do have a familial or genetic form, as compared to 30 to 50% of dilated or cardiomyopathy cases or arrhythmogenic cardiomyopathy cases. Hypertrophic cardiomyopathy is very common, 1 in 500 people. Well, you all know the clinical picture, but from the pathology point of view, myocardial disarray is a well-known phenomenon. It's generally transmitted as an autosomal dominant disease, meaning that there's a 50% chance of giving the mutation leading to the gene to the next generation. So it's present in multiple generations. Oh, it looks like it's going automatically or something, Thais. And males can hand it over to males. So those are the basic aspects of autosomal dominant inheritance. One other thing that's very important is reduced penetrance. That's what you see on the top right. That means that not everyone with the mutation does develop disease. On the top right, you see that 60% of the ones that have the mutation actually get disease. And the pedigree that you see here is on arrhythmogenic cardiomyopathy. 2 individuals have this disease due to an SCN5A mutation, but some only have atrial fibrillation or any other signs or symptoms, and that's what we call variable expression. So there are signs in the patient, but not the full phenotype. The penetrance in arrhythmo or in hypertrophic cardiomyopathy can be seen here, and I think it's a nice rule of thumb that from the age of 25 or 30, your age is roughly the penetrance. So a 40-year-old mutation carrier has a 40% chance of developing or of having a diagnosis of hypertrophic cardiomyopathy, and it goes up till old age. So for 80-year-old mutation carriers, it's roughly 80%. So there always remains a chance to develop disease. Well, if we move to the genetics of hypertrophic cardiomyopathy, like you all know, the overwhelming majority of genes involved in hypertrophic cardiomyopathy encode the proteins of the cardiac sarcomere, and myosin binding protein C3 and myosin heavy chain are the most important genes. But on the right, you can see that also metabolic diseases or malformation syndromes or other disorders can lead to a clinical diagnosis of hypertrophic cardiomyopathy, but the percentage is much lower. If we can move to the next one. So I think it's of utmost importance that you as cardiologists always think about, is this case of hypertrophic cardiomyopathy? Is it just isolated case of hypertrophic cardiomyopathy, or are other cardiac features present, or even other features that point to multi-system disease? So it's never enough just to take a look at the echocardiogram. You also have to find out whether there's conduction disease, WPW, structural heart abnormalities, or if we can move to the next one, other signs of symptoms, people looking slightly differently or having neurological problems that can point towards a different diagnosis. And also, if you request a genetic test, this information is paramount to interpret a genetic test. If we can move to the next one. So again, why should we do a genetic test for cardiogenetic disease? Well, first of all, is to confirm the genetic character and the mode of inheritance. And we also discussed in the discussion on arrhythmogenic cardiomyopathy that doing a genetic test is important for cascade screening of family members, for pre-symptomatic testing, but also for prenatal or pre-implantation diagnostics, it can be of importance. Well, it can be important to confirm a diagnosis, for example, in borderline cases, specific subtypes or because of criteria. And it can be important for risk stratification, particularly if there's a relation between genotype and phenotype. And of course, from a scientific point of view, it's important understanding disease, finding mechanisms, finding ways to influence those, and of course, identify novel genes. And finally, and that's more or less in the future, gene therapy might come to the playing field as well. And nowadays we have those myosin inhibitors where it's also important to know the mechanism of disease. So there are quite some reasons to perform a genetic test. But before requesting a genetic test, you should know which genes are relevant for, in this case, hypertrophic cardiomyopathy. And there's a ClinGen working group on cardiovascular genetics that studies whether genes are important and are associated with a specific disease. Just to give you an impression, for hypertrophic cardiomyopathy, more than 100 genes have been proposed to be related to hypertrophic cardiomyopathy. But is the evidence sufficient? That's something we definitely have to study, and that has been studied in this ClinGen initiative. If we can move to the next one. And that ClinGen initiative basically scores the genetic evidence that has been published in literature, the experimental evidence, and then defines whether there's a definitive, strong, moderate, or only limited association between that specific gene and disease. If we can move to the next one. And that was done for hypertrophic cardiomyopathy, and of the nearly 100 genes, actually only 9 turned out to have strong or definitive evidence to be related to hypertrophic cardiomyopathy, and another 2 genes had limited evidence. And that's something you definitely have to keep in mind, that not every variant that has been identified, not every gene that has been identified is related to disease. We can move to the next one. And this has also been done for dilated cardiomyopathy, ARVC, etc., etc. And the numbers of genes that actually do have sufficient evidence is for the overwhelming majority of those diseases only limited. And the next step is of course interpretation of variants. You know, we have the genes, which variants are important in those genes, and for that we use the ACMG, the American College of Medical Genetics criteria. We can move to the next one, and that's basically an algorithm to score several aspects of a variant in your DNA, and it basically adds up that score, leading to a specific estimation of pathogenicity. Can we move to the next one? The next one again. So this is basically the rules, yeah, but we don't discuss this in detail. But it's important to realize that the outcome of this algorithm is not a yes or no. It's basically, if we can move to the next one, a 5-class determination of pathogenicity. Class 4 and 5, likely pathogenic and pathogenic, are being used in clinical practice nowadays. Class 4, likely pathogenic, they do have a chance of 90 to 95% of being the likelihood of being the cause of disease. Class 5 is over 95%, and class 3 is the most important one. Those are the variants of uncertain significance, where you have to do additional studies to get more evidence, either in favor or against a specific variant. As you can see, it has a likelihood of being pathogenic between 10 and 90%. But class 4 and 5 are used in everyday clinical practice. Well, in the most recent guidelines for hypertrophic cardiomyopathy, as you can see in the second and third box, genetic testing is being thought to be beneficial and important for family members, and also to study atypic forms of hypertrophic cardiomyopathy. So that ClinGen initiative also moves on from identifying genes to studying variants or studying specific genes. And that has been done for MYH7, for example. And now we're working on other genes as well. So the general framework of the ECMG is adapted or modified for specific genes to improve the quality of interpretation of genetic variants. We can move to the next one. But however, sometimes we do get a negative test. But why is that? Well, first of all, because it's a non-genetic disorder. You know, there's something else externally that leads to a cardiomyopathy-like phenotype. The other thing is that the test characteristics might lead to a negative genetic test. For example, the specific part of the gene is not covered well enough, so the specific part of the gene is not being amplified sufficiently to be able to make an accurate interpretation of the presence or absence of a specific variant. Another reason could be that the bioinformatics tool is not sufficient, or another reason for a negative test might be that the wrong genes were selected. So known cardiomyopathy genes are not in the panel. Another reason is that the specific mutation or variant is outside the genes itself. There are parts of your DNA that actually regulate the gene transcription, and those are areas that can be far away from the gene itself, and those parts of the gene are often not evaluated. That's only done while using whole genome sequencing, and that's still very expensive, and the tests we use nowadays are often exome-based, And in those exomes, we only have 1 to 2% of your DNA. So you can miss information. And our Australian colleagues, and that's on the next slide, have studied or have done whole genome sequencing in patients with hypertrophic cardiomyopathy without a mutation. And they were able to identify an additional 9% of yield in patients or families without a mutation. So those that whole genome sequencing can definitely lead to additional yield of genetic testing. Genetic disease can also be present in the absence of a family history. For example, when there's consanguinity, meaning that parents are related to each other, and if they both carry a recessive allele and both pass it on to the next generation, so that the child has 2 copies, it may lead to disease. And then it's often only one child that is affected. Another reason why a genetic disease can be present in the absence of a family history, if when a mutation is new in an individual. So passing on from one generation to the other generation, a mutation had occurred. We have studied this for ARVC, and in ARVC, this was only very rarely present. And that's also true for hypertrophic cardiomyopathy. It is present, though, more often than arrhythmogenic cardiomyopathy. But in hypertrophic cardiomyopathy, we do have a lot of mutations that come from previous generations. If we can move to the next one. Genetic disease can also be present in the absence of a family history if there's non-paternity, so the father is not the father. Well, that has been calculated in the Netherlands. Over there, it's less than 1%. But I can imagine that there are some national differences between that percentage. But I don't know. So I cannot give you a percentage for Brazil. Another reason why disease can be genetic without one of the parents being affected, that is mosaicism. And that's basically when a mutation is only present in a small part of your cells. And it can be a part of the cells within the body or only in the germline. And it often doesn't lead to disease in that specific parent. And the other thing is that disease often seems not genetic, but that has to do with small family size. You know, if you only have 2 parents and 1 sibling, the chance of identifying another affected individual is small. And finally, not every disease is genetic. We do have Mendelian disease or near Mendelian disease, but also common variants or influences from outside can lead to disease. This is a very exciting field. We discussed it extensively, the role of exercise in arrhythmogenic cardiomyopathy, where we know that it leads to an earlier diagnosis and a more severe disease. And that has also been studied in hypertrophic cardiomyopathy. If you can move to the next one, in myosin light chain 2 gene mutations, they studied the role of hypertension, and that's the top panel on your right. There you see that those patients with a mutation and hypertension, 17 of 18 had a clinical diagnosis of hypertrophic cardiomyopathy, whereas those without hypertension, it was roughly 50-50. Half of them had developed disease. And they also studied the role of all risk factors for cardiovascular disease. So hypertension, overweight, high cholesterol, etc. So the traditional risk factors for atherosclerosis. And there you see that, again, if those risk factors are present, the penetrance of hypertrophic cardiomyopathy is again 24 out of 27 with those with risk factors, as compared to only 4 out of 11 in those without any risk factors. So again, additional external risk factors influence the penetrance of hypertrophic cardiomyopathy. And what we know very well is that having more than one mutation, for example, in myosin binding protein C3 is associated with severe disease. We know truncating mutations in myosin binding protein C very well. It leads to hypertrophic cardiomyopathy, generally at adult age. But if a child is unlucky and gets it from both parents, these children often die at young age. And what is young age? You're talking about weeks to months. So showing that the more mutations, the more severe disease. This is also known for the combination of multiple mutations in different hypertrophic cardiomyopathy genes. Again, earlier presentations, more symptoms, more sudden cardiac death events. So it's important to establish whether two mutations are present, yes or no. And the geneticist also needs the clinical input for this. So therefore, you as cardiologists are of paramount importance for the interpretation of genetic tests. Another example of genotype-phenotype relation is a high degree of sudden cardiac death, for example, in troponin T as compared to myosin binding protein C, which is nearly doubled as compared to MYBPC3, but also MYH7. Hypertrophy, slightly less in troponin T, delayed expression, myosin binding protein C, and finally MYH7 mutation lead to much earlier onset as compared to MYBPC3. And this information is therefore important for you as cardiologists. Our colleagues from Australia have extensively studied the non-familial hypertrophic cardiomyopathy. So if the family members, close family members, do not have hypertrophic cardiomyopathy, and if no mutation has been identified, the course of disease in those patients is much milder as compared to those with a mutation or with familial disease. And they even conclude that in those family members, you don't have to follow them up anymore, or if you follow them up, you do not have to do that at such a relatively small intervals. So that's another reason why evaluating family members and performing a genetic test is important as well, also for risk stratification. Family screening, hypertrophic cardiomyopathy, again, it's also in the most recent guidelines. Performing a genetic test is important, but also clinical screening is of importance. We can move to the next one. And what we do is something we call cascade genetic testing. We start with the patient, we perform a DNA test, we either identify a mutation or do not. And irrespective of that, we give a family letter to the index patient and ask him or her to hand it out to the first-degree family members. That you can see in this pedigree, we ask to hand out this family to the persons in blue. And if the one with the dot carry the mutation, we continue with that specific part of the family. So in this case, the mother of the index patient, those relatives are of importance, and we can ignore the father side of the family. That's something we call cascade genetic testing. That's quite intensive, but it leads to additional patients, individuals, family members that are at risk to develop disease. And what we know is that, and that has been studied in the Netherlands, that for hypertrophic cardiomyopathy, the study on your left side, 42% of relatives come to the clinic. And another study from colleagues, different place in the Netherlands, they identified a 39% uptake of genetic counseling and predictive DNA testing within 1 year. And so that's not 100%. And that was a reason why another PhD student studied, if we can move to the next one, what happened with the uptake of genetic counseling and predictive DNA testing after, let's say, 10 to 15 years. And that's what you can see, that it slightly increased to up to 58, 60%. But most of the patients come within the first 1 or 2 years after the identification of the index patient. So still not 100%. Can we move to the next one? And because this is so time consuming and very intensive, and in the Netherlands the request for genetic testing goes up 5 to 10% per year, and we do not get any additional money, so we have to do things more efficient. So we are thinking about replacing this family information letter and genetic counseling by a platform on the internet that provides information, that helps making choices. And we also have a virtual assistant that recognizes emotion, and that can help you through the decision process. So how does it work? The index patient gets this personalized link to the platform. There, that person can get information, and it's layered information. So if he or she wants to know more, you can go to the next level, etc., etc. It's on the disorder, it's on the genetics, it's on the mutation. The family member can ask questions, either to the chatbot or can chat with one of us. And of course, it's always possible to have a regular visit or a screen-to-screen conversation. DNA sample can be taken at home, and then we move to the result of the test that can be put on that platform as well. And we have those patients evaluated locally, and we organize an automated follow-up. And this online platform is tailor-made, so disease, gene, and mutation specific. And that's something we are currently building, and we want to test, and it helps to cope with the enormous numbers of patients that are coming to our clinic nowadays. And that brings me to the last slide. Well, your work as cardiologist is very important, because cardiologists and the cardiologist test results fuels the genetic interpretation, either genes or variants. But you should help us, if you identify severe phenotype or additional features, either systemic or on EKG, please mention it. It directs the interpretation of genetics. Genetics is important in hypertrophic cardiomyopathy, for family screening, genotype-phenotype relations. You always have to keep in mind that genes have to be relevant, that variants that you have identified have to be relevant before you use them in everyday clinical practice. Family screening is not something that happens automatically. You definitely have to do something with it. And hypertrophic cardiomyopathy can still be genetic, even with a genetic test. With this, I would like to thank you all, and particularly Thijs for helping me to present the slides. And I'm more than happy to take any questions.
Okay. Just a second. Thank you very much for this very clear and rich presentation. And it was very delightful to have you with us. And Thais wants to make a question.
No, so thank you for the presentation, Peter. It was really well, it was really good. I always learn a lot with the way you explain and gives the lessons. So my question was pretty much about I think one of the first things I was dazzled about HCM when I started studying it was because it was such an heterogeneous disease, genetically speaking. So I was also in doubt once we started to have our first genetic results here in Brazil. I noticed that there were some patients that, for example, had also positive mutations for Noonan disease, but they didn't have a phenotype, or they had an ALPK3 mutation also with a positive known, well-established correlated mutation for HCM. So you mentioned the worst prognosis of having more than one mutation, and my doubt was whether these mutations which do not have a phenotype of that specific disease, I don't know if you understand what I mean, also count as a worsening in prognosis of these patients or not.
Yeah, well, that's a great question, Thais, and that's always the main challenge. So if you do identify a Noonan variant in a patient that does not have any sign or symptom of Noonan syndrome, with the exception of hypertrophic cardiomyopathy, and you also identified a well-established sarcomeric variant, just to contribute. I think in situations like that, you definitely have to go back to the patient. First of all, are there really no signs or symptoms of Noonan syndrome? You know, I highly respect all cardiologists, but I know in the Netherlands, not all cardiologists are good in recognizing features of Noonan syndrome, or we discussed desmoplakin in woolly hair, or hyperkeratosis on hands or feet. So I would definitely discuss the specific patient with a clinical geneticist, or if it's a child, with a pediatrician. But for other genes, you know, ALPK3, you give that example, is an established hypertrophic cardiomyopathy gene. So it could definitely add up. But I am the first to admit that we do not have sufficient information yet on the combination of sarcomeric genes and ALPK3. We are currently doing a study in dilated cardiomyopathy. And what we do see is that, for example, in titin, patients with a titin mutation and an additional mutation leading to dilated cardiomyopathy, their phenotype is not more severe as compared to the average dilated cardiomyopathy. We did the same one for the phospholamban gene mutation, which is highly prevalent in the Netherlands. Those patients with that phospholamban mutation and a mutation on top of that, either leading to, for example, leading to dilated cardiomyopathy or leading to ARVC, their phenotype is average. You know, it starts between 30 and 50, you know, with signs of arrhythmogenic cardiomyopathy, or sometimes more dilated form. But it's not the 20-year-old that was resuscitated while playing soccer, or was transplanted at that age. So to be honest, there's still a lot to learn about the combination of multiple mutations or multiple variants. But for specific variants, you know, combinations, sarcomeric variants, and combinations of sarcomeric variants in different sarcomeric genes, it has been well established. But I think it's a great challenge for you to identify all those sarcomeric gene mutation patients with ALPK3 on top of that.
Nice, thank you. I have another question, if I may, really quickly. So you showed a very interesting work that you saw that intronic parts of the gene also showed some variations that were identified in hypertrophic cardiomyopathy patients. And so I was wondering, if you have a patient that has HCM, which is probably genetic, looks like genetic because it's an early stage in life, and you don't find a mutation, and that person has kids. So how should I follow the first degree relatives of the patient that you didn't actually identify a mutation, but are you just gonna not follow? For example, I always like to use the example of kids because, well, they are the most in risk people. How does it work, the follow up with those people then?
Yeah, what we currently do is, of course, after the identification of the index patient, we evaluate the first degree relatives, so parents, children, and siblings. And if no one has signs of hypertrophic cardiomyopathy, until now we continue to evaluate them, but we take longer intervals. So we used to see those relatives every 2 to 3 years, but nowadays we make this every 5 to 10 years. So the intervals are longer. But of course, we explain what the signs of or symptoms of hypertrophic cardiomyopathy are and urge them to come to the clinic earlier once they experience signs or symptoms of that, well, hypertrophic cardiomyopathy.
Yeah, I think it's nice to highlight that, because I think when we have a negative genetic test, I think it's important to tell people or patients that they're not really, well, you can forget that the cardiologist exists and just not worry about it anymore.
Yeah, but that, if a mutation has been identified in the index patient and the relative is negative, we also reassure them and tell them that the chance to develop hypertrophic cardiomyopathy is for them similar. Yeah,
but I mean, like the patients that do not have a mutation identified, but they might have a genetic disease, but because it's just in 60% that we actually find something, right? Yeah. But doesn't mean that they don't have.
No. Well, the study from Australia for the deep intronic variance identified a few additional % of patients with a genetic cause. But again, whole genome sequencing is so expensive, is still expensive, and well, also in the Netherlands, is not everyday clinical practice yet. So that we basically follow them up clinically, but the intervals we take are a bit longer. But again, I anticipate that whole genome sequencing gets the normal way to evaluate patients within the next, I don't know, 5 years or something. So we will definitely also re-evaluate the older patients that were initially negative.
Okay, thank you very much.
Martin?
Yeah, congratulations, Professor Van Tittelen. I think that you give very important clues to how to interpret a genetic study and how to proceed with a negative study and try to differentiate that not all genetic studies are the same. So this is important for clinicians to differentiate. No, I always make a comparison with matches study, and if you send a patient to a specialist in cardiac MRI, it's not the same that another center that do not have experience in seeing images of the heart in MRI. So I think the genetic study is the same. I agree with you that sometimes, with talking about rasopathies, that sometimes cardiologists are not very aware to distinguish some minor clinical sign of the diseases, and when when the genetic study return to us, we start to defining the phenotype, and And another thing is with the genome. I agree with you that it's costly for us, and we have a politics because in hypertrophic cardiomyopathy, for example, myosin binding protein C is the gene that do not tolerate haploinsufficiency. If haploinsufficiency is not every gene, for example, beta myosin heavy chain deep intronic variants, I think that are not important, but myosin binding, yes. So we decide to create custom panels, including the whole gene in those particular genes that are vinculated with haploinsufficiency intolerances. My question is, how do you proceed in those family who presented a very clear familial diseases, and do you have a variant of unknown significance? You go ahead with the family screening in a research setting. You stop. Not all the variants of unknown significance are the same. What is your position?
No, what we basically do is, well, the number one thing is that clinical evaluation by you as cardiologists is the starting point. So if we do have this index patient and we do identify a VUS, there's always a reason to evaluate the family members. And once we have identified another affected relative, we test that specific VUS in that affected person. We do not test for VUSs in patients that do not have a phenotype. You know, that has to do with the penetrance curve, because, you know, if someone is 35 years, there's still a 65% chance of developing hypertrophic cardiomyopathy. So the presence of that VUS in a 35-year-old or 55-year-old, whether it's present or absent, doesn't really help you. The only thing that can be helpful if you test the parents. So if you have the index patient with a variant which is not present in the parents, that means that this mutation is de novo, so started in that person as the first one in the family. If the phenotype is not present in the parents, then that's helpful as well. But we always continue with evaluating the VUS in additional affected family members.
Martin?
No, we do the same. We do the same and recognize that not all VUS are the same, because you have genes that have more powerful to explain the disease. But another question is, when you have enough information on the co-segregation on that VUS to establish a predictive value to this variant, because it's difficult. Imagine that you only test those patients affected, and then you find another relative that is affected and is carrying the mutation, and they go to another. But when you give the jump to pass this variant in a candidate gene or lower evidence gene to make it as a predictive test in the rest of the family?
Yeah, well, that's a very interesting question, and also within that ClinGen initiative I was talking about, where we study the relevance of genes and variants, we often have discussion on how much segregation you need to make a variant a likely pathogenic or a pathogenic variant. And we haven't come to a conclusion, but just for your idea, in the old days of genetics, you know, I have gray hair, so I was involved in there. We had a thing called a lot score. So for a specific region, this lot score had to be 3 to be sufficient evidence that that gene or region was involved in disease. And a lot score of 3 meant that there is 1,000 to 1 chance that that specific region or gene was involved in disease. And for that lot score of 3, you had to have roughly, it's a kind of estimation, let's say 10 10 steps from one individual to another, or let's say if it's few siblings, then you easily get to, if you have many siblings, you let's say if you have 6 siblings, you easily add it up to 6 steps. But imagine if you do have a third-degree cousin so far away, then you go to your parents, to your grandparents, to your great-grandparents, and there you go down again. Then you might end up with 7 or 8 steps between those individuals. And that's already roughly a lot score between 2 and 2.5. So that's already a chance of 100, 200 to 1 that variant is disease causing. So identifying a VUS just in one sibling who is affected is simply not enough, because the coincidence factor is simply too high. So we are quite conservative in this, and in Utrecht, where I work, we say that you have to have at least 5 steps, like I just explained in the pedigree, or affected siblings or parents or whatever, to move it from VUS to likely pathogenic. But again, it's difficult, you know. Also, a functional study can help to get additional information. Nowadays, we often study those iPSC cells, and that sometimes also helps to interpret the genetic variant and make the pathogenicity a bit higher. But it's a major challenge.
Yeah, I agree. Or work with deep intronic variants to make RNA analysis, or to construct a mini gen to see if this variant is really altering the transcription of the product of the gene. Thank you very much.
So we are going deep in terms of trying to figure out what we have in our hands sometimes. But I would like to be a little bit shallow. Professor Van Tintelen, something about frequency of hypertrophic cardiomyopathy. Once, old studies told us about 1 to 500. What do you think about this?
Yeah, well, are we talking about clinical phenotype, or are we talking about the presence of a?
I would like to challenge you to say that all the papers that I read about not all, but almost all, it's written over there. Hypertrophic cardiomyopathy, the prevalence is 1 per 500. Is it true?
If you talk about the clinical phenotype, I think it might be a bit lower. But if you talk about genetic preposition to hypertrophic cardiomyopathy, I think it might be higher. So we do have quite some population studies in the Netherlands, and as you might know, we do have quite some founder mutations. So that came from a common ancestor, I don't know, 10, 20 generations ago. And what we do see that only those founder mutations are already present in 1 in 400 to 1 in 500 people. And then you're only talking about 3 major NYBPC3 founder mutations. On top of that, we also have MYH7 and myosin light chain, troponin T, etc., etc. So the genetic presence is higher than 1 in 500, but the full clinical phenotype is, to my opinion, a bit lower than that 1 in 500.
So 1 to 500, it fits. It's an average, let's say.
Yeah, probably. I never thought about that, but that could be. Yeah.
The second question is regarding the state-of-the-art paper published on JACC by Ethan Rowling, Mary Martin Maron and Barry Maron 2 years ago. And there is an image that there is a father. He is the proband, and he has a myosin binding mutation, and he has 56 years. And at his MRI, he presented the basal part of the septum hypertrophied. His older son is positive for the same mutation, 33 years of age, and he has a septum of this size, huge, asymmetric, hypertrophic cardiomyopathy, clear 33 millimeters of septum. Another, that his daughter, 30-something, 31, she had the myosin binding, the positive genotype for the same mutation, but the MRI is normal. And the lucky one is a youngest daughter. She is negative for the mutation.
Yeah.
I would like you to talk a little bit expression of the disease when people have the same mutation. Can you give us a hint about this?
Gosh, I wish I could. No, I only a little bit. You know, as you can imagine, with the large founder populations that we do have in the Netherlands, we are in a unique position to sort this out. So it's a very clinically relevant question. So I think there are a few things that might help. Well, the first of all is additional genetic factors. You know, you can think of rare variants that might be a bit more detrimental. But you might also know about the polygenic risk scores. So the combination of, let's say, 10 or 20 common variants in the population that can add up on top of this monogenic mutation in MYBPC3. So I think that could definitely be a something that contributes to disease. Well, I mentioned the traditional factors leading to vascular disease, the hypertension, the high cholesterol, the people not being active, people with overweight. You know, those factors also contribute to the development of hypertrophic cardiomyopathy, which has been demonstrated already a few times. But the most important thing is that we simply do not have a full explanation yet why this expressivity of hypertrophic cardiomyopathy, but also other inherited cardiomyopathy is so huge. We have families with the 20-year-old being transplanted, you know, while grandfather or grandmother, 80 years old with the same mutation, is still actively running around and on EKG or an echo are only very mild and subtle abnormalities. So the true answer is that we still do not know the full picture, what leads to this variability, and there's still a lot to do. What we are currently doing is also studying on a cardiac tissue level whether there are differences between, you know, severely affected individuals and less affected individuals. But still, it's still a long way to go.
Even one good example could be twins, identical twins.
Yeah, we all have those examples.
Yes.
Yeah.
My last question is again a tricky one. We are in the era of, for example, mavacamten, these myosin inhibitors, and we are in the era of Explorer HCM, and now just published in Circulation the Valor trial, 32 weeks of the Valor trial, showing benefits of this kind of medication in some let's say, not hard outcomes, but very important outcomes. Maybe quality of life and functional capacity can be judged as, inverted comma, hard outcomes for some people. I was thinking early this morning, and I decided to ask you this question. Sorry. What do you think about this kind of medication? Maybe a new order in terms of clinical treatment of hypertrophic cardiomyopathy and personalized medicine for that specific individual with that specific mutation. Maybe the drug will act better than for another mutation. Have you ever think about this?
Oh yeah, sure. It's the times are very exciting, with the new medication that comes around, but also with gene therapy that's already being tested for some disorders. But the thing that worries me most are a few things. So one of them is what happens with potential side effects. So that novel therapy is great for the patient, makes him or her feel better on his cardiac condition, but does it have any important side effects? And how will it work in the long run? But the most important thing is, well, to my opinion, is the availability of that specific medication. For example, in the Netherlands, it hasn't been approved of yet to be used as a medication. That's one step. And the next step is that I don't know how it is in Brazil, but in the Netherlands, the cost of healthcare are growing so fast that the government has decided that over the next 3 years, we are not allowed to grow anymore. So the amount of money that's being spent on healthcare will stay the same over the next couple of years. So what is being communicated in the Netherlands is, dear people of the Netherlands, we cannot afford anymore everything that's present. So I think we definitely have to prepare that we cannot do anything anymore that's present in the world. And I don't know exactly the price of mavacamten, but it's probably huge, given the high numbers of patients that are there. So that's something that definitely worries me. And again, the Netherlands is a rich country. But what about other parts of the world? So the availability and that's something that worries me most. But again, I think these medications is a unique opportunity, but there are definitely some concerns. But I'm more than happy to hear your opinion.
Okay, it's very interesting your government opinion. I never thought about this. Is the other side of the coin, because here we are very excited about, let's say, mavacamten, but the cost in the United States is $90,000 per year. This is unaffordable here in Brazil, and I don't know in terms of cost efficacy is bad for sure. I don't need to make a calculation to say, but here in Brazil, this drug actually the drug has a name. It's Camurus from BMS, and Anvisa, our regulatory agency, is approving the drug in the next few weeks, and the price will not be $90,000, but it will be huge. And here in Brazil, we have a terrible problem. It's called judicialized medicine. I don't know if there is a translation for this. People, they enter in the justice, they ask for the government to pay, the government and the health system to pay for very, very, very expensive medicine because some judge just sign and say, this person must to use the medicine. There is no money for this. Instead, on the other hand, how many hypertensive patients we have here, Martin? How many patients who are starving over here and so on? So it's something that we must discuss, and the opinion of your government is a very interesting one. Last year, I be on the board of BMS for this medication. And this is something that should be discussed. And these guys, they for sure, they are looking for selling the medication, and fair enough. And it's great that the Valor trial, 32 weeks, showed these results. Very good, especially in people who are eligible for myectomy.
Yeah.
But should we put money on this? Thais, what do you think?
Well, that's tricky. Yeah, I think you have a very good point, a valid point, that we cannot afford because we are lacking basic medication for some people, and we're spending money on very expensive for a few people. So I think in Brazil still there's a lot of structural problems. I don't think, I think it's still a very tricky discussion because it doesn't have, I think, the basics still figured out. And so the expensive drugs are very, very tricky to involve government money, let's say. I think in the beginning in Brazil, like I think every technology first, it's going to be available for people that actually can privately afford it. But we should think about the logistics in a global and in a bigger picture way. And I agree with you that the government of the Netherlands has also this way of, well, because I think I'm sure that they have, the health system a bit better structured there. So I think they can say, okay, people, this is, let's cover the basics first, and let's start filtering what's actually important. Well, we cannot afford just for a few, we have to afford for everyone if we're going to start doing this. So I think this is very, rational, I think, from the government.
Yeah, but the other side of the coin is, of course, if there's something available that helps people to feel better and maybe improve their physical abilities, gosh, imagine if you're being that patient yourself, and that pill is around the corner, and you just cannot reach it, and you feel bad, and it could help you feel better. It must be frustrating not to get this medication.
Yeah, for sure, I agree with you. But at the same time, in Brazil, we still have patients with other more prevalent diseases like hypertension and diabetes. That still don't get the care that they should be getting for, So it is tricky. Yeah, it's a very hard question. It is. I don't think I have a very good opinion still about it.
It's an ethical discussion.
Yes.
The fact is, it's better to have this kind of medication than don't have. But the fact is, should we look for bivalent COVID vaccine right now, or to look for something like this, where we will put the money? I think that the companies who are doing a study these kind of drugs, we should congratulate them. But we must have another step, this kind of discussion that you point out, and is very important.
Yeah, and again, you know, it's very exciting that basic science and understanding what leads to disease also can lead to a therapy. But one day, you know, and it might take another 10 years or maybe even longer. The availability will probably be no issue at all. But still, you know, those companies, yeah, they particularly in the beginning, they request substantial amounts of money for that medication, and prices eventually will go down.
This is the Moore law, the computer Moore law that we use for medicine. Martin, do you have any opinion regarding this?
No, completely agree with you, with this bipolar sensation of be happy with this new medication, but the great difficulty to set down to the general population. There is plenty of drugs like this, tafamidis for amyloidosis, inotersen, and not to talk about oncology drugs, and I think it is a big problem.
Yeah. Well, it's 12:51 p.m. Here in Brazil, and it's time to finish our second day of presentations and discussion in the International Symposium of Cardiovascular Genetics. It was a pleasure to be here this morning. We had fantastic presentations, and the discussions, they were delightful, besides very thoughtful, and we learned a lot with each other. So this is great. I think our audience could learn a little bit more about what we are thinking, what is being done. And just before finishing, I will like to remember you that next Saturday, 8:30 Brasilia time, we'll start with canalopathies, Brugada and short and long QT syndrome. Then we will move to some other canalopathies, then dyslipidemia and genetics, and we will finish with gene therapy, the future, and cardiovascular diseases, mainly hypertrophic cardiomyopathy. Professor Van Tintelen, Professor Martin, Thais, the audience, Uzi, who is helping us with the technical issues. I thank you very much for everything, and let's meet next week at the same time in the same channel. Thank you very much. Bye-bye, everybody. Take care.
Thank you.